correlation with cytogenetic or fish finding and the CPC values?
Yes, sir.
The
Actually,
ISS did not match.
Yes, sir. We could able to get in our institute. We don't do routinely fish in the own department, so we are outsourcing the samples. So we could only able to get only for 66 patients fish reports from the outside reports, which was not statistically significant, sir. We have done the correlation study. I have not shown here, but it was not statistically significant.
None of the cytogenetic changes, like 17p, were not more in higher.
Actually, sir, in 19 patients, 13q deletion were more, sir. Nine patients, and the other patients like each has one translocations and the other abnormalities were found. It was not similar to all the patients, and also we could not get the post because I am a PhD scholar from the institute. So routinely they don't send the bone marrow sample to the department. I personally have to go and collect the samples. Many drawbacks were there to get the samples from the bone marrow. So, and also peripheral blood we have collected, but many times I may not be able to get the samples, and they forgot to send the samples. It was.
The last question, where do you place this current study as far as the Indian perspective is concerned? Where will you place this evaluation of the peripheral clonal plasma cells? At which stage of the myeloma disease?
Like it's
at diagnosis, post-treatment, where would you like to place this evaluation as part of your routine?
At diagnosis, sir. At diagnosis, like we can able to see the level of CPCs at baseline, and we can able to tell them the after 4 to 6 cycles of therapy, we can tell them how the prognostic significance will be. Thank you, sir. Thank you so much.
Nice presentation, Satya. And now we have Dr. Ashwin Anand Pai.
Good morning to one and all present here. I'm Ashwin Anand Pai, working as Senior Research Fellow from Department of Hematology, CMC Vellore. And I'm going to present data on the project which focused on personalizing melphalan conditioning for multiple myeloma autologous stem cell transplantation. How to change the slides? This. I'm sorry? All right. Okay, so giving a brief background, ASCT with HDM, high dose melphalan, is a standard consolidation treatment for transplant eligible multiple myeloma. However, it is still challenged by inevitable relapses threatening long-term remissions. Various PK studies report 10-fold variation in melphalan exposure, resulting in variable ASCT outcomes. And some of the previous studies, especially with the Australian group, they suggested that increased melphalan exposure was associated with severe mucositis, but better overall survival. Of recent, PK-guided dosing, especially test dose strategies, are claimed to minimize toxicities and increase the efficacy of ASCT. We previously published a paper on CLML with 63 patients with multiple myeloma, where we evaluated the pharmacokinetics and clinical efficacy of two different formulations, the generic and the innovator, where we found that both the formulations were bioequivalent in terms of clinical efficacy and pharmacokinetics. So therefore, generic MEL is a good alternative for Indian setting. However, we did not evaluate the dose exposure response in this study, because at that moment the study was not mature and was not powered to do outcome analysis. Therefore, the present study aimed to evaluate the dose exposure response relationship of melphalan in a uniform cohort or an extended cohort of 120 patients with multiple myeloma, and we evaluated the impact of MEL exposure on early toxicities and early outcome and long-term outcome. Moving on to methodology, consecutive patients with multiple myeloma receiving standard dose melphalan or renal adjusted to 140 were included in the analysis. We collected patient peripheral blood samples at different time points on the day of MEL conditioning, and plasma was separated and stored, and then we have an in-house validated LCMS methodology for estimating plasma MEL levels. Therefore, we calculated estimated the plasma MEL levels, and then we also performed a POPPK modeling using non-MEM software. And then we compared the MEL PK, which is the exposure and the clearance, with clinical outcomes. This table represents the demographics, baseline parameters. So 120 patients were enrolled in the study with a median of 53. There was a male preponderance, and based on the pre-ASCT response, 59% had complete response, 34 had very good partial response, 25 had very partial response, and based on the maintenance therapy, 98 patients received immunomodulatory regimen. Moving on to results, 120 patients were enrolled in the study, but however 112 patients had PK data, and for several reasons we did not have PK data for 8 patients, and we performed a 2-compartmental POPPK modeling which best described our data. And we also observed there was a 10-fold inter-individual variability, as you can see in the first figure, and with a median of 13.6 in our cohort. And also based on other, when compared to other demographic factors, we see that MEL clearance was decreased in females, decreased with increasing age, and increased with increasing creatinine clearance. So therefore, significant inter-individual variability in MEL exposure was explained by age, female sex, and creatinine clearance. Moving on to ASCT outcomes, and a median follow-up of 36 months, 35 patients had relapsed. All patients had mucositis extending maximum to grade 3 in 80%, grade 2 in 18.3%, grade 1 in 2% at last follow-up. Disease relapse was the most common cause of death, accounting for 79%, and in our cohort, OS and EFS was 83.3% and 67%. And then we performed outcome analysis with MEL exposure and various outcomes such as engraftment, mucositis, etc. However, we did not find any significant association between MEL exposure and transplant-related toxicity, including mucositis. Surprisingly, we did not even observe that high MEL exposure was associated with regimen-related toxicities and early ASCT outcomes. Then we wanted to see if there is a impact of MEL exposure on survival. Therefore, we did a Kaplan-Meier analysis, and we seen that we observed that patients who had higher than the median MEL exposure, that is 13.6 in the present cohort, had significantly poor overall survival and poor event-free survival. As you could see in the first graph, the blue, which is patients less than 13.6, 57 patients had 90%, that is the 90% versus 78% in patients who had higher MEL exposure. Also, in event-free survival was very poor in patients who had higher MEL exposure, that is in green, that is 72% versus 62%. So we observed that high MEL exposure significantly was associated with poor OS and EFS. Then we wanted to see whether is this a serendipitous finding or not. Therefore, we did a multivariate analysis, and we incorporate several risk factors such as age, remission status, pre and post ASCT response, type of maintenance therapy, and we see, interestingly, we see that only MEL exposure was associated with poor EFS, and of that, again, higher MEL exposure, that is greater than 13.6, was very significantly associated with poor EFS, with a that is at least 3 times the risk factor. Therefore, high MEL exposure predicts poor EFS. Of late, and over the 3-4 years, there are recent evidences suggesting that high-dose melphalan increases mutational burden and relapse, especially by Dr. Munshi's group. And the paper was way back in 2020, where patients who underwent ASCT with high-dose melphalan, they identified there was a mutational signature, that is SBS-MM1, in patients who were exposed to high-dose melphalan in autologous setting. And the last week there was a paper from Dr. Munshi again in the blood, where again there was a randomized study where they find that at relapse, a patient who received HDM plus RVD had higher mutational burden compared to patients who were not exposed to high-dose melphalan. I'm sorry. The signature was detected in relapsed refractory myeloma patients exclusively. So moving on to discussion, this is the first large single-center study to identify high MEL exposure risk factor for poor OS EFS. We did not find any association with RRTs. As we know that it's highly mutagenic agent, it is well acknowledged that systemic seeding of residual surviving subclones can lead to relapse. We hypothesized that magnitude of drug exposure, that is high MEL exposure, could drive mutational process leading to relapse. And we show that high MEL exposure associated with poor EFS and OS, and we are now trying to find it biologically, to validate our present finding in vitro. I would like to acknowledge Dr. Pungareddy, CMC Vellore, Dr. Uday, Dr. Biju, Dr. Vikram, Dr. Anup, and Dr. Carl from US funding agency. Thank you so much.
Nice presentation, thank you. The multivariable model that you showed,
Yes.
You included both the AUC as well as the AUC over 13.6 in
Yes.
the same model,
Yes.
but they are correlated variables.
I'm sorry, in two different analysis. So one with MEL exposure as a continuous variable, and then other one as a cutoff.
So the table is not from a single model.
No, but they are not from a single model, but no. So we did two different multivariate analysis. That is one end model is what I've shown here.
Okay.
That is incorporating both the variables. I've done both as well.
Any thought why creatinine clearance is impacting so much? Do you have any sense of, is it also a continuous relationship versus, because I couldn't see the curve that you showed,
Yes.
and the relationship between creatinine clearance and the MEL exposure.
Yes.
Is it, is there a certain, what kind of correlation is between the two?
So MEL clearance was increased with patients with increased creatinine
What was
clearance.
the correlation coefficient for that?
I am.
Or how strong it was?
It was not that strong. It was not that strong. It was
Because in general, melphalan is not as excreted through kidney that
Yes.
becomes a big issue. But it's interesting.
Yes, it was not that strong.
Yeah,
Sir.
it's a good, very good data.
Thank you.
When you did a multivariate analysis,
Yes.
you included both pre and post transplant response status.
Yes, sir.
So this response is evaluated by a MRD technique or by the routine SPP SIF SFLC.
It was routine technique.
So you didn't look at the depth of the response pre and post transplant.
You mean MRD, sir? Yes. So MRD data was not available for all the patients because it became a routine care since 2019. So I had data available only for a few patients. So denominator was too less, the MRD status, but the routine. So these
The response is basically the
Yes.
VGPR PR.
Yes.
Okay,
Yes.
fine.
Thank you. Thank you so much.
And now we have Dr. Akshay Lahoti.
Good morning everyone, good morning one and all. I am Dr. Akshay, Clinical Associate at Tata Medical Center, Kolkata, and I'll be presenting the results of analysis of multiple myeloma patients with underlying CRF who underwent stem cell transplantation in last 10 years at our center. I have no conflict of interest. So coming to the background, autologous stem cell transplantation has improved the disease outcome of multiple myeloma. Chronic renal failure is the most common complication associated with multiple myeloma patients, and the safety and efficacy of ACT in renal failure has been the subject of debate since last many years. Often renal failure patients are excluded from SCT due to growing concern of drug toxicity and TRMs. So there has been a debate, and few previous studies, retrospective studies, have highlighted increased morbidity and mortality in renal failure, while the few recent ones have shown that it is quite safe to perform ACT in these patients. So with the same intent, and per se the data from the Indian population is also very scarce on this topic, so we did an audit with the objectives being the primary objective to assess the safety of SCT in patients of multiple myeloma with renal failure, and the secondary objectives being the time of neutrophil platelet engraftment, duration of hospitalization, response rates at post-transplant day 60, and survival outcomes including the OFS and the PFS. So this is a single center retrospective observational study and the patients included were all the patients of multiple myeloma who underwent SCT but with renal failure at the time of transplant, and the renal failure was defined as the EGFR less than 60 ml per minute with the CKD EPI creatinine equation. Male and female patients who were more than 18 and less than 65 were included with a performance status of less than equal to 2. The statistical analysis was done by using the SPSS version 26, and the survival data were analyzed by Kaplan-Meier statistics. So the consort of this audit is quite simple. So we retrieved all the electronic microelectrical records of 132 consecutive patients of multiple myeloma who underwent SCT between 2011 and 2022, of which 9 patients were having CRF at the time of transplant. So we have analyzed the parameters and the outcomes of these 9 patients, which I will be subsequently discussing in the subsequent slides. Status at the last follow-up, which was almost at the median of 5 years. So 7 patients are alive and 2 are no more. So when we discuss about their parameters, so median age was around 54 years. The range was between 41 to 64 years. Majority of them being male. The median eGFR in our cohort was around 36 with a range of 18 to 54. VTD was the most common regimen, followed by VCD. 5 of the patients required prelixafor for mobilization and 4 were mobilized with the GCSF only. Median CD34 stem cell dose was around 5.7 million cells per kg. All the patients received melphalan 140 mg per meter square as conditioning, and stem cell was infused almost 24 hours after giving melphalan. Median days of neutrophil and platelet engraftment were around 11 and 10 days respectively, and the median duration of hospital days were 21. When we see the safety of these patients, so there was no TRM in none of the 9 patients. Although all the patients had febrile neutropenia, many of them had mucositis more than equal to grade 3. 2 of the patients had neurologic complications, including one had GTCS 6 hours after melphalan infusion, and one of the patient had encephalopathy, probably melphalan induced, and one had a transient AF with some hemodynamic instability for which he required ICU hospitalization also. One patient required temporary hemodialysis and he required almost 3 to 4 sessions. After that he is dialysis free. 2 of the patients, one with a neurologic complication and one with cardiac, required ICU stay for almost 5 to 7 days. For the antibiotic usage, 4 patients required second line, 4 required the third line antibiotics, and 1 required the salvage antibiotics during the hospital stay. When we discuss about the disease status, so majority of them were in stringent CR post-transplant versus many of them were in CR and stringent CR pre-transplant. After a median follow-up of almost 5 years, median EFS was 3.5 years, while overall survival in our population has not been reached. So when discuss renal involvement and inadequate renal responses are known to be independent markers in multiple myeloma patients. ACT is feasible and has been reported with good outcomes in the recent retrospective studies. Morbidity has improved over the last few years with the better supportive care, which is the crux for the myeloma patients with CRF who undergo transplants. Febrile neutropenia was higher in our population as expected, and despite increased prevalence of MDRO, the transplant-related mortality was not increased. Non-infectious complications were comparable with the patients with non-CRF. So to conclude, ASAT in myeloma with pre-existing renal failure is feasible with clinically manageable toxicity profile, and it is not associated with increased TRM in our population. These are the references. And I would like to acknowledge Image Group and Tata Medical Center for giving this opportunity to me. Thank you.
So do you have any data on change in the renal function after transplant?
So we have, but this was done only at day 60, and there was no significant improvement in the median GFR levels versus day 60 versus the baseline before the transplant.
And you had 130 plus patients and only 9 had renal failure. How many had renal failure at the diagnosis that persisted till pre-transplant? Do you have that number?
So
I mean,
these
that's
are
not part of your study, so
Yes,
that's
sir.
okay. If you don't have it, that's okay.
so not analyzed although. Yes.
Good study.
Good presentation. The kind of a related question, given the fact that a higher proportion of patients in India present with renal failure compared to the Western data, you only have like 7% of people with a creatinine clearance of less than 60 here. Is that because of some kind of a pre-screening that happens for people being considered for transplant?
Yes, sir. So most of the patients, we counsel them that there might be increased morbidity or mortality as compared what we have seen previously. So most of the patients do not opt for transplant, and that is why there is a lot of attrition rates when we take those patients for transplant.
And the cause of death was what, myeloma related or non-myeloma related?
Sir, it was myeloma related, but the two patients who expired, that was almost 1 year and 3 years after the transplant. So probably it was the disease which came back, and it was the relapse which caused the death. There was no TRM during the transplant period.
I've got two queries. Now, one, how renal dysfunction is a huge spectrum. So how many of them actually were dialysis dependent? How many non-dialysis dependent? And based on the staging of the CKD, so which stages? So you are 9 patients fitted into one. That's question number one. And question number two, you use 2021 criteria for defining renal dysfunction, whereas your cohort starts from 2011 onwards, wherein the calculation of EGFR, the GFR or the renal dysfunction was based on Cochrane-Gault. So does that make any difference in your evaluation or the analysis?
So when we took the patient this time, so this study was done from all the patients, but this CKD EPI equation was put during the analysis time. So that was not during the time when the patient were taken for the transplant. And secondly, the EGFR was less than 60 was taken for all the patients because there were only 9 patients. So we cannot make the comparison based on the small number of patients. So therefore it was taken as one group only.
Dialysis dependence and
So
non-dialysis.
no patient was dialysis dependent. Only one required dialysis during the transplant period. And the same patient had sepsis, uremic encephalopathy, also melphalan induced encephalopathy, but that was transiently required. So probably dialysis facility, if it is there in the transplant unit when these patients are taken, would be a better thing to be thought of.
Okay,
Thank you, sir.
thank you.
Now we have Dr. Atul Basna.
A very good morning to all the dignitaries present here. My name is Atul Basnal and I'm a PhD scholar from AIIMS New Delhi. And the topic of my presentation is liquid biopsy to detect somatic mutations and monitor disease kinetics using NGS and dt-PCR in multiple myeloma. So as we know, collection of bone marrow is a painful procedure for the patient, and also there is spatio-temporal heterogeneity in multiple myeloma, wherein different biopsy sites may have different set of mutations. So liquid biopsy may become an alternative to this problem because in circulation there is input from all the tumor sites. So cell-free DNA is released from cancer cells as well as healthy cells undergoing apoptosis, necrosis and active secretion. Cell-free DNA is double-stranded and contains small fragments around 175 base pairs and large fragments around 21 kb. So the aim and objective of this study is to identify somatic mutations in the bone marrow at diagnosis and tracking of disease burden using cell-free DNA at follow-up time point in multiple myeloma patients, and correlation of cell-free DNA mutations with conventional response. So this is an ongoing study and we included 151 newly diagnosed multiple myeloma patients as per IMWG criteria. For each patient, levels of SPEP, SFLC and cell-free DNA profiles were obtained before and after therapy. Cell-free DNA was collected at multiple time points during treatment follow-ups. At baseline, targeted NGS has been performed on CD138 positive cells and ddPCR has been performed on cell-free DNA samples to validate the mutations. In the follow-up cell-free DNA samples, ddPCR has been performed for longitudinal tracking of baseline mutations. And finally, the correlation of conventional response with cell-free DNA mutations was done. So to characterize the mutation spectrum of myeloma patients and to identify mutations for cell-free DNA tracking, targeted NGS has been performed on bone marrow plasma cell DNA using a custom panel of genes specific for multiple myeloma. Libraries were prepared using Illumina's custom Amplicon low input kit, and paired end sequencing was done using Illumina's MySeq platform to achieve more than 2000x coverage for each patient. And finally, annotation was done using NOR. So using various filtering criteria and removing germline mutations, pathogenic mutations were found in the patients, and most frequently mutated genes were KRAS, NRAS, BRAF, FAT3, FAT4, DNAH5 and TP53. At least one pathogenic mutation was found in 56% of the patients, and 16% of the patients had mutation in more than one gene. And RAS and RAF mutations were found to be mutually exclusive except for one case. These are KRAS and NRAS pathogenic variants distribution in multiple myeloma patients. Among these, KRAS Q61H and NRAS Q61R had the highest frequency in our cohort. KRAS, NRAS and BRAF ddPCR assays were used to validate the most frequent mutations detected by NGS in the bone marrow pcDNA, and comparable results were obtained between the two techniques. And these 5 assays were picked up for longitudinal tracking of mutations in cell-free DNA samples. Cell-free DNA isolated from peripheral blood plasma of healthy controls and myeloma patients, and their yield and quality was checked by qubit, bioanalyzer and RT-PCR. Amount of cell-free DNA was significantly higher in myeloma patients as compared to healthy controls. Then we set out to find whether the same mutations that were detected in bone marrow DNA are detectable in cell-free DNA by ddPCR or not. So we picked up the most frequent mutations for validation of our concept and found that 95% of the patients had detectable cell-free DNA mutations. Only 2 patients had undetectable cell-free DNA mutations, and their bone marrow frequency was 10.1% and 33%. So there may be some sample related issue in these 2 samples. Finally, cell-free DNA mutant allele frequency was compared with conventional response, and a good correlation was found. This table shows 17 patients with paired cell-free DNA sample, and we had 22 responses from these 17 patients. So when the patient is going into remission, the mutation frequency also going down, and when the patient is progressing, cell-free DNA frequency is also going up. So I'll just show 2 representative cases where multi-time point data was available. In the first case, patient achieved VGPR and then CR, and the value of both M protein and cell-free DNA mutant allele frequency also goes down. And in second case, where patient progressed, the value of both M protein and cell-free DNA mutant allele frequency also increased. So from these observations, we concluded that cell-free DNA is a reliable and specific marker of response assessment in multiple myeloma. I would like to express my special thanks to my supervisor, Professor Ritu Gupta, for giving me an opportunity to work in this project, and all the team members. Thank you.
Were you able to detect those mutations in the blood even before the M spike started going up in any of the patients?
Before the M protein, sir, there was a case where the cell-free DNA concentration was going up, but M protein going down, and the patient was progressed. Clinically, there was clinical progression. Maybe in PET-CT there was clinical progression. So cell-free DNA proved to be beneficial in that case.
So how do you use this data to say what added value does it have to clinically say there is progression over and above the M protein?
Yeah, because the response was calculated with M protein and all the parameters like SFLC and PET-CT if available. So yes, the correlation was found very nicely in our data.
Did you have any correlation between the bone marrow plasma cell or myeloma cell content and ability to detect cfDNA? If I understood right, you only focused on RAS for your cfDNA, not more genome-wide
Yes.
cfDNA
Yes.
sequencing, right?
Yes.
Just with PCR.
Yes, actually, sir, this is an ongoing study. I have to order the probes for TP53 also. We have found, so it's an ongoing study. I have just, done 2 times the ddPCR, so initial results are there. So in future, we will track more mutations.
And there were no cases where you found it in cfDNA but not in the bone marrow.
No cases were there.
Thank you.
The amount of plasma cells in the marrow and the cfDNA, there was no correlation.
Sir, there is data, but we have not correlated actually. So,
Okay.
so it's an ongoing study. So, okay. Thank you, sir.
And now we have Dr. Aishwarya Dhabe.
Good morning, everyone. So today I'll be presenting on a systematic stepwise strategy for risk stratified therapy in plasma cell neoplasms at our setting. So as we know, the primary cytogenetic abnormalities comprise of the IGH translocations and the trisomies for the odd number of chromosomes, and the secondary cytogenetic abnormalities comprise of the 17p deletions, 1q amplifications, 1p deletions, and the MYC translocations. So this was a retrospective study of 542 cases collected from January 2017 to June 2022. The bone marrow samples that we received were subjected to magnetic cell sorting for plasma cell enrichment technique. So these enriched fish slides were made from these enriched samples, and they were further tested for fish for 17p deletion and IGH gene rearrangements. If they were positive for IGH gene rearrangements, we would further test for translocation 1114, translocation 414, and translocation 1416. So we followed this strategy up till December 2017, post which we learnt that majority of our cohort presented with translocation 414 as compared to translocation 1114, and we were not identifying 1p deletions and 1q gain bar amplification cases, and we were not detecting cases of hyperdiploides. So use of smaller cover slips and addition of lesser amount of probes, we could add more amount of markers on one slide to reduce the cost for the patient. So we came up with a revised strategy. So along with TP53 deletion and IGH gene rearrangement, we also incorporated testing for 1p deletion, 1q gain bar amplification, and for trisomies for 5, 9, 15, we had a tricolor probe that we used. So in this scenario, if the cases were positive for IGH gene rearrangement, we would further test them for translocation 414, 614, and 1114. If they were positive for translocation 614 and 1114, they were termed as the standard risk markers, and if they were negative, they were the high risk markers. Similarly, if it was positive for translocation 414, it was high risk, and if it was negative, we would further fish for other high risk partners. So the other partners that we tested were for c-MYC gene rearrangements, the translocation 1416 and the translocation 1420. So this was a patient, total cohort was 542, the median age group was 59.7 years with a male preponderance. So based on the laboratory parameters, a majority of our patients, around 60%, presented with anemia and bone lytic lesions, and the majority immunoglobulin subtype which is noted was the IgG followed by the IgA subtype. So here, as we see, on the x-axis we have the plasma cells, and on the y-axis we have the number of cases. So a total of abnormal cytogenetics was noted as 63% in our total of 542 cases. And as the number of plasma cells increased, the number of cytogenetic abnormalities increased. I would also like to note that even with a plasma cell percentage of less than 10% in the bone marrow aspirate, we were about to find abnormal cytogenetics in about 40 to 50% cases. Coming to the primary cytogenetic abnormalities, the IGH gene rearrangements were noted in 124 cases, of which the majority patients were translocation 414, followed by translocation 1114. And we also noted a c-MYC gene rearrangement in around 10% cases. So in our strategy, whenever IGH was positive and the partner was not known, apart from 414, 1114 and 614, then we would test for the further high-risk markers like c-MYC, 1416 and 1420. So we were around, we found around 12 cases which were positive for c-MYC gene rearrangement, and these cases presented with hypercalcemia, plasmablastic morphology, and also majority were associated with 1Q amplification. Coming to the hyperdiploidy, this was incorporated from 2018, and as we see on the left hand side is an inverted DAPI image showing the gain pattern for 5, 9 and 15. So in our cohort, around 41% cases were positive for hyperdiploidy. Coming to the secondary cytogenetic abnormalities, so the chromosome 1 related abnormalities, which included overall 1p deletion as well as 1q gain bar amplification, was noted in 40% cases, and only a 1q gain bar amplification was seen in about 34% cases. Similarly, the 17p deletions were noted in around 9% cases, and this was completely done in all the 542 cases that we had seen. So the total cost of our panel, including all the markers, is around 10,000 rupees, and the cost of the full panel, including only the 4 markers, is around 6,500. So by using the probes adequately and by limiting the amount of probe that is used and the smaller cover slips, we were about to save around 35% cost for our patients. So this was an interesting case of a 72-year-old male who presented with lytic lesions and blood counts which were suggestive of a myeloproliferative neoplasm. The peripheral blood fish confirmed the positivity for BCR-ABL1 fusion, and on the bone marrow aspirate was performed in view of the lytic lesions. So the bone marrow aspirate showed a picture like CML with 5% plasma cells, and on biochemical parameters we saw an IgG kappa restriction. So on the bone marrow biopsy, interestingly, a few of the intramedullary spaces showed CML-like features, and remaining intramedullary spaces showed sheets of clonal plasma cells, which in IHC were confirmed by CD138 positivity, CD56, and showed kappa chain restriction. So as the bone marrow was performed, we performed a fish for myeloma panel, and on the CD138 enriched samples, and we found 3 copies, that is gain of the 1q gene. So we thought that is this same cell, is it coming from the same cell? To check the clonality, we also performed fish for BCR-ABL1 fusion on the enriched plasma cells, and it was positive in around 40% of the cells. So to confirm our suspicion, we co-hybridized both these probes and we put it on the enriched plasma cells, and it was positive for both BCR-ABL1 fusion as well as 1q gain in the same cell, confirming that probably they were coming from the same pluripotent stem cell. So to conclude, an overall abnormal cytogenetics was seen in 63% cases, and the frequency of c-MYC translocations in our cohort is less, is probably because we checked only the ones which were IGH gene rearranged. So by using plasma cell enrichment techniques and judicious use of the probes, you can have a properly risk stratified setting for cytogenetics in low resource settings. Thank you.
Thank you, nice presentation. Why did you end up just adding all 3 probes, the 414, 1114 and 614?
Yes, sir.
If the reason for changing was because the 414 was more frequent, then why didn't you just do 414 alone and then sequentially add the others?
No, first ruling out standard risk together, we would put even 614 and 1114 together.
Right. But you could have saved the 614 and 1114 probes for the majority of the patients.
But to rule out a standard risk together, so like together, that's one.
Very good work. The patient who had both CML and how many cells had both BCR-ABL and myeloma
40%,
markers?
like it was equal in both. Like 1Q gain was also seen in 40% and BCR-ABL fusion was also seen in 40%.
But how many are in the same cell?
Yeah, 40%.
40%
Yeah,
cell is in the
similar,
same
yes,
cell.
sir, yes, sir.
It's very interesting. And second thing, doing this, are you able to judge the clonality, or have you looked for the clonality of some of the changes? So for example, 1114, was it 100% of the cells or proportion? 17P is a better example.
Yeah, so in our setting what we do is we have two readers who will analyze about 100 cells and an average percentage is taken of the cells, and we have different cutoffs for different probes. So like for a deletion probe we have a 10% cutoff, for a fusion probe similarly like we have a cutoff. So
And
based
last
on
question, so you had IgM myeloma.
that. Yeah.
Any specific about those, or you haven't analyzed yet?
No, we haven't analyzed.
Thank you.
A quick one, I know we are crossing the time. Your title talks about stepwise systematic cytogenetic strategy for risk stratified therapy. Your title and your work does not match. Beautiful work, great results, but there's nothing about therapy
So
here.
the stepwise is that, yes,
we are only talking about stratifying people by a
Yes, sir.
stepwise strategy.
Yes, sir.
Period.
Yes, sir.
Nothing related to
So
therapy.
based on that, it will be classified as standard risk, high risk, because we also get like trisomies plus a 1Q gain amplification. Like you will have multiple abnormalities towards in our entire panel that is seen.
So stratification is just not cytogenetics. You have got other
It's-
factors.
Yeah,
into
but
it.
for us, this
So
is like a side.
And now we have Dr. Rajat Pincha.
Good morning, everyone. I'm Dr. Rajat Pincha from Tata Medical Center. The topic for my presentation is bortezomib, pomalidomide, and dexamethasone as a novel induction therapy in newly diagnosed patient with multiple myeloma. These are updated results from my ongoing phase 2 trial. I have no conflict of interest related to this presentation. Background: as we all know that bortezomib containing triplets are the standard of care in patients with newly diagnosed multiple myeloma.
Just give us a minute.
understand. They can view from the side screen. Okay. Good morning, everyone. The topic is bortezomib, pomalidomide, and dexamethasone as an induction therapy in newly diagnosed patients with multiple myeloma. As we all know that bortezomib containing triplets are the standard of care in newly diagnosed patients with multiple myeloma, and pomalidomide has shown as a good response rate in relapse and refractory myeloma patients, and it has been approved by the various regulatory authorities in relapse and refractory setting. As discussed yesterday in multiple academic sessions, that myeloma MRD assessment using different tools has shown as improvement in overall survival and progression-free survival. So that forms the rationale for our study. The aim of the study was to determine the activity and safety of a combination of pomalidomide, bortezomib, and dexamethasone as an upfront therapy in newly diagnosed patients with multiple myeloma. And the primary objective was to determine the minimal residual disease by flow cytometry at 9 months of therapy. And the secondary objectives being the overall response rate, progression-free survival, and safety analysis. Methods is a prospective single-arm phase 2 study. We aim to recruit a minimum of 30 and maximum of 55 patients. Inclusion criteria were the newly diagnosed patients with myeloma between 18 and 70 years of age, and both transplant eligible and ineligible patients were included. The major exclusion criteria being plasma cell leukemia, POEM syndrome, amyloidosis, and any pre-existing significant peripheral neuropathy. And in the study procedure, the eligible patients received subcutaneous bortezomib at a dose of 1.3 milligram per square meter, tablet pomalidomide 2 to 4 milligram once daily for 21 days, and tablet dexamethasone 40 milligram per week in a 20-day 8 cycle for a total of 9 to 12 cycles, and eligible patients who underwent transplant between 4 to 6 cycles of therapy. Coming to the schema, after initial screening and looking for the eligibility, we had the baseline parameters done, and after 4 cycles of therapy, we had a response assessment done with both bone marrow morphology and biochemical parameters, and including MRD. Transplant eligible patients were allowed for transplant between 4 to 6 cycles of therapy, and after completion of transplant, they were again put on VPD to complete a total of 9 cycles of therapy. And in the transplant ineligible patients, the patients went on to receive a total of 9 to 12 cycles of therapy, followed by maintenance that was institutional protocol, and MRD was assessed at the end of 4 months, 9 months, and 12 months. Methods: we used a 2-tube 8-color antibody panel for myeloma MRD assessment, and a value of less than 0.001% was considered as negative. The responses were as per the IMWG criteria. Event was calculated as progression, death, or time to subsequent treatment, whichever was earlier. And Kaplan-Meier analysis was used to calculate the survival probability. Now coming to the results, median age was 55 years, and we have almost equal number of male and female patients. Bony lesions were the most common in approximately 97% of patients, and the majority of the patients belong to the RISS 2 category, and a quarter of patients were RISS 3, that is the high risk. We enrolled a total of 36 patients. 2 patients withdrew consent early in the study, and 34 patients completed 4 cycles of therapy, and 5 are active on the trial currently. 26 patients completed 9 cycles of therapy, and 5 patients had undergone bone marrow transplant after high dose therapy, and 17 patients have completed 12 cycles of therapy. Now coming to the response, in the intent to treat population, post cycle 4 we have approximately 85% of patients who had shown an overall response rate, and in post cycle 9 we have approximately 65% of the patients who have shown an overall response rate, which I must mention that we have 11 patients who were non-evaluable, and in majority of them are 5 patients are currently active on the trial, and because of the mortality we could not assess the response post cycle 9. And if we see the overall response rate in the evaluable patient, it was 100% post cycle 4 and 92% in post cycle 9. Now when we look at the MRD results, it was quite surprising. In the overall, it were 53% patients and 81% patients were MRD negative post cycle 4 and 9 respectively, and in the evaluable patients the number were even more. Altogether 5 patients underwent transplant, none failed mobilization, and 2 patients required plerixafor in addition with GCSF for mobilization. Now coming to the toxicities, we have, as expected, hematological toxicities were the most common. However, the grade 3 and grade 4 were manageable. Among the non-hematological toxicities, diarrhea, rash and peripheral neuropathy were the most common. However, the rates were quite low. Now deaths, we have altogether 5 deaths. We must admit that the study was carried out in the COVID pandemic. One had progressive disease, and other causes are there, including COVID pneumonia, sudden cardiac death, intracranial hemorrhage, and sepsis. When we look at the survival, we had a median follow-up of 20.5 months, and median estimated progression-free survival at 2 years was 92%. And when we look at the event-free survival, it was approximately 75%. Now discussion, as we can see in the current study, in the intent to treat population, the MRD negative rates were far better than the VRD regimen, which we commonly employ in our Indian settings, and it was comparable to the DARA VRD regimen as we use in the Griffin study. Now coming to the conclusion, VPT is an effective and safe induction regimen for newly diagnosed patients with myeloma, and it has shown as good MRD negativity rate and responses. VPT may be a promising induction regimen in resource constant settings like ours, where daratumumab is not readily accessible, to gain a better depth of response. Phase 3 trials are the way forward for its clinical use in frontline settings. These are my references. I'd like to acknowledge Image team for the platform, Tata Medical Center for the opportunity, and my colleague Dr. Navid Tamboli, who was instrumental in initiating the work. Thank you.
Good presentation. The pomalidomide dose, you said 2 to 4 milligrams. How did you decide which patients are getting?
We started at 2 milligrams of pomalidomide, and we try to maintain a absolute neutrophil count of above 1000, and if the patients were tolerating, in the subsequent cycle we increased to 3 milligram and up to a maximum of 4 milligram.
And the comparisons you did, you compared the MRD rate, even though a lot of the patients didn't really have the MRD assessments. How did the complete response rates compare with what has been presented for VRD at the end of cycle 4?
So at the end of cycle 4, we have in the evaluable patients, the patients who were evaluable, we have approximately 100% overall response rate. And in the MRD, sir, in the MRD response, we have 2 patients who were MRD positive post cycle 4 out of 34 patients, evaluable patients, sir. So, like, even though the patients were showing overall response rate, 2 patients were had MRD positivity, and subsequently 1 patient progressed in the group who had MRD positivity.
Did you have the what happened on the transplant side? The 5 patients got transplanted.
Yes, sir.
What was their outcome?
So, for the patients who underwent transplant, 4 patients were already MRD negative, 1 was MRD positive, and the patient who was MRD positive after transplant at 9 cycles of therapy, he became transplant negative. All the patients are alive, sir.
And what was the sensitivity of MRD testing?
It was less than 0.001%, was taken as 10 to the minus 5, sir.
Thank you.
Thank you, Dr. Rajat. Now we have Dr. Rashmi.
Good morning, everyone. Myself, Dr. Rashmi Avalkar from Amrita Institute of Medical Science, Kochi. Today, I will be presenting bortezomib maintenance appears feasible, safe, and effective in newly diagnosed multiple myeloma in a resource-limited setting, a retrospective analysis from South India. Maintenance therapy, post-induction or post-autologous stem cell transplant in newly diagnosed multiple myeloma represent a vital strategy to delay the disease progression and relapse. Lenalidomide was the first FDA approval oral drug in 2017 for maintenance after autologous stem cell transplant in multiple myeloma. Bortezomib is a first-class proteasome inhibitor widely used as an induction therapy for newly diagnosed multiple myeloma. Unlike lenalidomide, there is a less published data for the role of bortezomib in the maintenance therapy. The availability of generic drugs and subcutaneous route of administration has made a bortezomib a preferred drug for maintenance in lower middle income countries like India. Our aim was to analyze the regional real-world data on the outcome of bortezomib and lenalidomide-based maintenance in newly diagnosed multiple myeloma. The primary objective was to assess the reasons for discontinuation at 1 year of bortezomib and len-based maintenance, whereas secondary was to compare the overall survival and progression-free survival of both the groups. It was a two-center retrospective analysis done from January 2013 to December 2020. We have included all newly diagnosed multiple myeloma patients who receive induction with or without transplant, followed by either lenalidomide or bortezomib-based maintenance. And those who not started on maintenance or lost to follow-up before maintenance were excluded. The protocol was approved by the Institutional Review Board Committee. The data included demographics, clinical characteristics like ISS staging, induction regimen, transplant, maintenance therapy, adverse event, relapse, and responses up to the last follow-up date. Response were assessed as per the IMWG criteria. Bortezomib maintenance was defined as 1.3 mg per meter square once every 2 weeks, administered subcutaneously alone or in combination with the other drug. Whereas len maintenance was defined as oral tablets that 10 mg per day increased up to the 15 mg per day for 21 days in a month based on the drug tolerance of the patient. Bortezomib in combination with the lenalidomide was considered under the bortezomib maintenance during the analysis. The progression-free survival we calculated from the date of initiation of induction to the relapse or death, whichever came earlier, and the overall survival from the date of initiation of induction till death. The time to event analysis was performed using the Kaplan-Meier method to assess the PFS and OS in both the group. The log rank test was used to assess the difference between the group. All statistical analyses were performed using the IBM SPSS version 26 software. Coming to the result, this is the flow chart of patient selection for our study group. We have screened total 550 patients from January 2013 to December 2020, out of which 431 were newly diagnosed multiple myeloma. 419 patients received the induction, 71 underwent the transplant, and 274 received the maintenance therapy. Out of 274 patients who received the maintenance therapy, 176, that is 65% of the patient had bortezomib based, and 97, that is the 35% of the patient had len-based maintenance. This is the table showing a comparison of the two groups. Both the groups were comparable across majority of the variable. The median age for both the groups were 60 years. Male predominance in the bortezomib based. As per the FISH criteria, high risk was more in the bortezomib-based group. Majority of the patient in both the group received VCD as an induction regimen. 20% underwent transplant in bortezomib and 28% of the patient underwent transplant in lenalidomide. 75% of the patient completed 1 year of maintenance with the bortezomib-based, and 79% of the patient completed 1 year of maintenance in len-based. Coming to the safety, that is the reason for the discontinuation in the bortezomib-based, total 25% patient discontinued within the 1 year. The reasons were 12% had progression, 2% of the patient developed drug toxicity in the form of peripheral neuropathy, thrombocytopenia, whereas in the lenalidomide-based 20% discontinued within the 1 year. The reasons were 8 had progression, 5.1% of the patients showed drug toxicity in the form of fatigue, DVT, and secondary malignancy in the form of CA prostate. This is the survival analysis. If you see this is the first graph on the left hand side. It is showing the Kaplan-Meier plot showing the median progression-free survival for 1 year bortezomib maintenance and len-based maintenance in newly diagnosed multiple myeloma were 53 months and 46 months respectively. And if you look at the right hand side, this is the overall survival, and you can clearly see that we did not reach we could not get the 1 year, we could not get the median overall survival for the 1 year bortezomib based, whereas for the lenalidomide based maintenance, it was the 100-month. Coming to the discussion, compared to lenalidomide maintenance, nearly twice the number of patients were on the bortezomib maintenance. Both maintenance regimens seem to be well tolerated, with most patients completing 1 year. Progressive disease was the most common reason for discontinuation of maintenance in both the subgroup. OS and PSS were similar in both the cohort. Coming to conclude, our study was limited by its retrospective nature. Risk stratification was not available in most cases. Patients who underwent transplant were limited in number even in those eligible, underlining the probable difficulty to expenses of the treatment in a LMIC. Compared maintenance therapy appeared much more accessible. Our study points toward the need to explore the outcome of bortezomib across the different cytogenetics and MRD subgroup as well as post-ASCT and non-HSCT setting. Thank you.
Very nice study and good patient numbers.
Yeah, thank you, sir.
Any explanation on how bortezomib was picked? What led to the investigators or physicians picking bortezomib versus lenalidomide?
The thing is, sir, we are, as per this FDA approval, we are giving this lenalidomide. Initially, we were giving the bortezomib. So there is a less data, and it is a generic drug. So we tried to look, because majority of the patient had received in our setting, in our hospital, that the bortezomib. So, and there, as per there is no data, less data is there. So we tried to look at this, and our majority of the patient were in the bortezomib group than the len group.
Nice study. What proportion of patients in the bortezomib group got bortezomib and lenalidomide?
It was out of 177, it was the 10 patient they had borti and lenser. Rest of the were the bortezomib based.
Dose of bortezomib was 1.3.
1.3. We are capping at the 2
At
mg.
2,
yeah,
okay.
yeah, capping at the 2.
And the dosing of bortezomib, was it different for those patients who had some sort of residual disease, or was it modified based on the residual disease?
Sir, the thing is, we are looking at the prospectively. We don't have this analysis, this MRD analysis. We are trying to do this as research.
And second thing, was the bortezomib once in 2 weeks, or was it weekly maintenance?
It was a twice weekly. Once in 2 weeks, fortnightly. Sorry.
One of the curious observation there, the difference in the gender balance. You think
Yeah, it is
men
a
are
male.
more likely to come in and get the injections?
What, sir?
Are men more likely to be willing to come back and get the? Do you know why it happened? Just
I
random.
really don't know. It was a retrospective study, sir. We'll forward. Thank you.
Yeah, I have a question, sorry, to your right side, top. So a lot of your patients...
Sorry, only judges are allowed to have questions.
Sorry, my fault.
Thank you.
And now we have Dr. Aditya Chandial.
Good morning everyone. I'm Dr. Aditya from PGI Chandigarh, and today I will be presenting the clinico-pathological profile and treatment outcomes in patients with MGRS from PGI Chandigarh. So when we talk about renal dysfunction in monoclonal gammopathies, we know that in the setting of high tumor burdens, light chains get precipitated in renal tubules and lead to cast nephropathy, which is the hallmark of myeloma related renal dysfunction. But there are other mechanisms also through which monoclonal immunoglobulins damage kidneys, and we now know that physicochemical properties, charge, glycosylations, mutations in various domains of immunoglobulin molecule can lead to kidney damage. And to address this aspect, the term MGRS came into picture, and it is similar to MGUS in terms of tumor bulk, but it is clearly different from MGUS patient because MGRS patients have pathological renal conditions which are, if untreated, go on to progress to ESRD. So IKMG came up with the formal definition of MGRS, and it particularly emphasized on two things. First, the size of the clone doesn't matter, and second, these patients should not be fitting into the criteria for established hematological malignancies. So MGRS, so there are multiple conditions that constitute MGRS, have different clinical, histopathological, immunofluorescence and EM findings. So when we talk about Indian experience, it is mostly limited to case reports, and with this background, we looked at the MGRS patients diagnosed and managed at our center for last 10 years, and we included patients who had confirmation of MGRS on renal biopsies, the patients with multiple myeloma who were diagnosed on the basis of CRAB criteria, those who had cast nephropathy and AL amyloidosis were excluded. So the median age of our patient population was 48 years, and median duration of symptoms was 6 months with a range of 1 to 24 months. And about half of patients had high blood pressure at diagnosis, 40% had comorbidities in the form of hypertension and diabetes, and 7 were dialysis dependent. So apart from fatigue and loss of appetite and weight, which were most common symptoms, pedal edema, proteinuria, and reduced urine output were the most common presenting features. Interestingly, one of the patient had presentation in the form of pyrexia of unknown origin with on and off fever for last 1 year, and ultimately diagnosed to have crystal storing histiocytosis. So the majority of the patients had kappa subtype as the paraprotein. SPEP and SIFP could pick up the paraprotein in about 50% of patients, and median serum creatinine was 2.6. 13 patients had nephrotic range proteinuria. So with the availability of EGFR 24-hour urine protein, we could find 3 main phenotypes in our patient population: isolated renal insufficiency, isolated proteinuria, or a mixed group. And we found that majority of the patients had renal insufficiency with or without proteinuria, and isolated proteinuria cases were just a minority, around 22% only. So the most common renal lesion was MIDD, followed by PGN-MID, C3 glomerulopathy, cryoglobulinic GN, and there was 1 case each of crystal storing histiocytosis and LCPT. 3 patients had more than 1 renal lesion. Majority of our patients received bortezomib-based therapy. The median duration of treatment was 8 months. 1/3 of them received maintenance therapy, 3 underwent autologous stem cell transplant, and 4 underwent renal transplant. So among 23 evaluable patients, the overall response rate was seen in around 73% patients, and about half of patients had CR or VGPR, and median time to hematological response was 6 months. So when we assessed the renal response, we found that patients who had renal insufficiency with or without proteinuria, they had inferior renal response as compared to those who had isolated proteinuria. And second thing I would highlight here is that IKMG group has given a formal definition of MGRS. So there are no standardized response criteria, uniform response criteria. So that is one of the gap in literature as of now. So 2 out of 7 dialysis dependent patients became dialysis independent, and median duration of best renal response was 12 months with range of 6 to 24 months. So highlighting that some of the patients continue to have deepening of the renal response beyond 1 year. So after a median follow-up of 8 months, the overall survival of study cohort was 77%. 7 patients died during follow-up, 2 because of COVID-related complications, and 4 because of advanced renal failure. So the major limitations of our study were the retrospective design. It was a small study, and we conclude that achievement of deep hematological response is possible with the clone-directed therapy. We actually need uniform response criteria, particularly for renal assessment in MGRS patients. And low GFR at baseline is possibly a risk factor for suboptimal renal response, and maybe one of the indications for using upfront monoclonal antibodies in such patients. And I think it is important for Indian centers to collect the data so that we can have robust information for this rare entity. Thank you.
Do you have the longitudinal data about how long before their diagnosis of MGRS did they have renal dysfunction?
So actually, sir, it is not available for all the patients, but I can share about 4 patients who came to our center with symptoms duration more than 12 months, and actually they had to undergo multiple renal biopsies, received therapy in the form of steroids for brief duration, showed some response, again relapsed, and then came to ultimately were diagnosed to have MGRS on 3rd biopsy or maybe on 2nd or 3rd biopsies.
But you don't have data that if they had mild renal dysfunction, say 2 years ago or 4 years ago?
That we don't have, sir. It is a retrospective.
Good work.
Great presentation. What proportion of patients were able to identify a clone in the bone marrow, and would you follow that?
So we had flow cytometry report showing plasma cells in not more than 4 or 5 patients, and the median bone marrow plasma cytosis, the median number of plasma cells was 4, and the number of patients having more than 5% plasma cells was 25% only.
And you said there were renal transplant, and how many patients had renal transplant and how many patients had bone marrow transplant?
So 3 patients underwent autologous stem cell transplant successfully, 4 patients underwent renal transplant, and 2 patients actually developed MGRS after a renal transplant had already been done for them. So they received further therapy.
So nobody received both?
Sir?
Nobody received both renal and
I don't think so. Thank you, sir.
And now we have Dr. Shelly Singla.
Good morning everyone. Myself Dr. Shelly Singla. I am from PGI Chandigarh. Today topic of our study is correlation of flow cytometric BCL2 and MCL1 expression with cytogenetic characteristics and outcome in multiple myeloma patients. As we know that BCL2 is a major anti-apoptotic protein, and the various targeted therapies have shown significant clinical activity for the treatment of hematological malignancies. In multiple myeloma cells, these are highly dependent on the BCL2 for the survival, and MCL also plays a very essential role for the pro-survival role. Venetoclax, we know that it is a highly selective oral BCL2 antagonist, and it has shown to improve survival in the relapsed refractory multiple myeloma patients, especially when cyclin D1 translocation is present or BCL2 expression is high. But it may only be effective in subset of patients who have the high BCL2 expression or low MCL1. High BCL2 expression or cyclin D1 translocation was shown to be predictive of response to venetoclax in multiple myeloma. MCL maps to the human chromosome 1q21, and the patients with amplification of chromosome 1q are highly sensitive to MCL1 targeting. Copy number gain of MCL1 and patient with BCL2 mutation can have resistance to the venetoclax. An occasional study has shown the cytogenetic correlation of the BCL2 and MCL1, and they have shown that the cyclin-driven translocation in the multiple myeloma patient have high BCL2 and low MCL1 expression, and patient with the translocation 414 and 1416 have high MCL1 and low BCL2 expression. But majority of the studies use either ISC or real-time quantitative PCR for studying BCL2 and MCL1, both of which are met with the challenges. Aim of our study was to study the expression of BCL2 and MCL1 by flow cytometry in the myeloma patients and to correlate their expression with the cytogenetic characteristics and outcome. It was a prospective study conducted over a period of 1 year. Following panel of antibodies was used, in which the gating markers of plasma cell were used and the cytoplasmic stain for BCL2 and MCL1 was used. At least 1 million events were acquired, and the various percentages of plasma cell positive for BCL2 and MCL1, MFI of BCL2 and MCL1, and various ratios were calculated for BCL2 and MCL1 on plasma cell and T cells. This is a flow cytometry plots. After the gating of plasma cells and on the basis of FMO control, threshold was decided for the BCL2 and MCL1 expression, and the MFI of the BCL2 and MCL1 on plasma cell and T cells were obtained. We had 143 total multiple myeloma cases, which included 103 newly diagnosed and 40 relapsed refractory, and 8 non-clonal plasma cells were obtained for the correlation. And these are the various hematological and clinical characteristics of the patients in our cohort, and the median age was 59 years. The most common cytogenetic abnormality in our cohort was 1q21 gain in 53% patients, and cyclin-driven translocation was seen in 6% of cases. And 1q21 was seen in predominantly all the cytogenetic abnormalities in the combination. When we compared the clonal plasma cells with the non-clonal plasma cells, we found that the ratio of the BCL2 with the on plasma cell T cells, MCL1 and BCL2 MCL1 ratio was significantly higher in the clonal plasma cells as compared to the non-clonal plasma cells. There was an occasional study which has showed that the BCL2 and MCL1 is overexpressed in the relapsed refractory multiple myeloma, but in our study when we compared the both groups, the expression levels were not significant between both groups. When we compared the BCL2 and MCL expression in various cytogenetic groups, we found that MCL1 MFI was significantly overexpressed in the patients which did not have the cyclin-driven translocation, and it was overexpressed in patients with 1q21 gain. And similarly, MCL1 ratio was also overexpressed in the 1q21 gain and the patients without the cyclin-driven translocation. When we compared only BCL2, it was not significant, but when we compared BCL2 versus MCL1 ratio, it was significantly more in the patients with cyclin-driven translocation. We categorize the BCL2 and MCL1 expression on the basis of weak, moderate and strong expression to see that which level of the expression is seen in these patients, in the cytogenetic groups. And as previously we saw, the MCL1 ratio in 75% of cases with cyclin-driven showed dim MCL1 ratio, and none of the cases had the strong ratio. And 69% of cases with 1q21 amplification had strong MCL1 ratio. And coming to the BCL2 versus MCL1 ratio, all the cases of cyclin-driven translocation had strong BCL2 versus MCL1 ratio, that is more than 50% of expression. There was no significant difference with the other expression markers between the cytogenetic groups. And the dim expression less than 25 percentile was seen of the BCL2, MCL1 and ratio in 25% of cases. And we compared the survival analysis, overall survival and progression-free survival between the various expression levels. There was no significant difference in the survival. So salient findings of a study are that in the myeloma cells, there is significantly higher BCL2 ratio, MCL1 ratio, BCL2 and MCL1 ratio. And there was no significant difference in BCL2 and MCL1 expression between the newly diagnosed and relapsed refractory multiple myeloma cases. There was no significant difference of BCL2 MFI and BCL2 ratio in cytogenetic groups. In cyclin-driven translocation, there was significantly lower dim MCL1 expression and higher BCL2 ratio. In 1q21 gain, there was significantly higher and strong MCL1 ratio. And in about 25% cases, they showed dim BCL2, MCL1 and BCL2 MCL1 ratio. To conclude, this is an objective assessment of BCL2 and MCL expression by flow cytometry. Strong MCL was most frequently seen in the 1q21 application, while cyclin D1 showed weakest expression of MCL1. A strong BCL to MCL1 ratio was detected in cyclin D1 translocation, and the cases where dim expression of BCL to MCL1 was seen, there the benefit of the anti-BCL2 or MCL targeted therapy is questionable, and routine testing of the BCL2 and MCL1 expression by flow cytometry may be beneficial before starting venetoclax or similar targeted therapies. Thank you.
So, very well done study, and I think there's a lot of, as you said, practical implications of this. If you try to correlate response to, say, bortezomib or dexamethasone based on this result in these patients?
We have data, but we have not correlated with the drug-based.
Because theoretically it can also get affected, that data doesn't exist very cleanly. Yes. So this might be a good chance to do it.
Yes.
Good work.
Thank you, sir.
Great work. What is the heterogeneity in the expression within the abnormal plasma cells for BCL2 and MCL1?
Okay, so BCL2, like, it ranged from the 10% to more 99 till the 99%
of the plasma cells.
Of the plasma cells, and so we compared the ratio with the T cells, and it was significant.
On today's date, excellent work. On today's date, where would you place this evaluation in a routine management of a myeloma patient? Would you advise everybody should undergo these evaluations?
Actually, when venetoclax is at the it's at the higher cost in India, but when it will be at lower cost, it can be effective in those patients which have the high BCL2 or and lower MCL1 expression. So at that time it can be used, and it can be beneficial. And in the cases which had the dim expression of the BCL2, they may be resistant to venetoclax.
Thank you.
Thank you, sir.
And now we have last presentation of the session, Dr. Sumit Mirk.
Good morning. My topic is comparison of various stem cell mobilization. Regimens for multiple myeloma, a 15-year retrospective institutional analysis from India. So we know that stem cells are mobilized to peripheral blood by either using GCSF plus chemotherapy, that is chemomobilization, or without chemotherapy, that is steady state mobilization. Cyclophosphamide-based mobilization can overcome the advantage of prior lenalidomide therapy, and can offer the advantage of increased stem cell yield. But because of the need for hospitalization and risk for febrile neutropenia, steady state mobilization is preferred. Until a few years back, cost of plerixafor was very prohibitive, and here we can see that until 2018 it was exorbitantly expensive, equaling the cost of a mobilization, after which generic drugs have become available. This therefore prompted a search for alternative cheaper drugs. Mouse models have shown that proteasome inhibitors help in stem cell mobilization by downregulating the VLA4, which interacts with the VCAM1 on stem cells. We previously reported 2 years back that BOT plus IGCSF versus IGCSF had a trend towards higher CD34 yield and reduced need for apheresis sessions without added toxicity. Hereby we report a 15-year experience of 4 different mobilization regimens for myeloma. So the options can include either cyclophosphamide based or GCSF plus plerixafor, or either of them in combination with bortezomib. So going back from our most recent regimens, group 1, BOT plus GCSF, 4 days of GCSF, 5 micron per kg subcutaneously BD, day 4 bortezomib, 12 to 14 hours prior to planned apheresis, day 4 and day 5 morning CD30 for estimation. Group 2, GCSF plus plerixafor, 4 days of GCSF, 4th day plerixafor, 11 hours prior to planned apheresis, CD30 for estimation on day 4, day 5 in the morning. In both group 1 and group 2, the harvest was a planned harvest on day 5 in the morning. Group 3, BOT GCSF, day 1 for 8-11 bortezomib, days 8 and 9 cyclophosphamide, from day 11 onwards GCSF, and CD30 for estimation from day 14 onwards. Group 4, Cy-GCSF, cyclophosphamide on days 1 and 2. Day 4 onwards G-CSF, day 10 onwards CD34 estimation. In both group 3 and group 4, it was a rainy day harvest once the peripheral blood CD34 was more than 20. Our primary objective was to determine proportion of patients with CD34 more than 5 million in the first apheresis in various groups. Secondly, median CD34 dose total of all the harvest, median CD34 in first apheresis, and frequency of mobilization failure, where it was defined as total CD34 less than 2 million or abandoned harvest attempt anticipating a post-stem cell collection. So all patients in the last 15 years between 18 to 65 who are transplant eligible, abandoned mobilization were included. It was an intention to treat cohort. Data was analyzed as per standard statistical methods. Data was updated November 22 in the first 2 groups and December 2019 in the last 2 groups. Results: 186 patients, median age of 48 years, 68% males. We can see that in various groups, the median age, the male and gender distribution, median lines of prior therapy, ISS distribution is comparable. However, in group 1, we had more CR VGPR at time of harvest in comparison to the other 3 groups. When we compare the baseline induction regimens, VRD was the most common induction regimen in group 1 and 2. VCD was the most common induction regimen in group 3 and 4. And this therefore accounts for a higher LEN exposure prior to harvest in the first 2 groups to the tunes of 70% and 95% respectively. However, the LEN duration prior to harvest was comparable in all the 4 groups. Coming to the primary outcome, patients who collected 5 million with a single apheresis, group 1 24%, group 2 50%, group 3 70%, and group 4 44%. So we can see that group 1 is performing inferiorly as compared to all the other groups. Group 3 is performing better in comparison to all the other groups. Most importantly, group 2 and group 4 are comparable. Coming to CD34 dose in first apheresis, we can see that the horizontal line appreciates a median value. Group 1 3.59, group 2 5.05, group 3 5.98, and group 4 6.12. No difference in the first 2 groups, no difference in the last 2 groups, no difference in second group versus both the cyclophosphamide groups, but the first group was inferior in comparison to both the cyclophosphamide groups. Total CD34 dose, group 1 5.58 million, group 2 6.61, group 3 9.2, and group 4 8.2 million. No difference in the first 2 groups, no difference in the last 2 groups, but when we compare both group 1 and group 2 versus both the cyclophosphamide groups, they performed inferiorly with respect to total CD34 dose. Plerixafor was used in 46% patients in group 1, 19% in group 3, 6.8% in group 4. In group 1 and 4, half of them received it preemptively, half of them therapeutically, whereas all in group 3 received it preemptively. Median number of apheresis sessions was comparable, but most important in group 2 and group 3, the median number of apheresis sessions was only 1. Mobilization failure was comparable in all the 4 groups. Coming to the patients who underwent a transplant, which is 70% patients, no difference in the median day of neutrophil engraftment, platelet engraftment, 2-year progression-free survival. However, while we see that there is a lesser risk of engraftment syndrome in group 4, it is not statistically significant. Comparing our data versus published Western literature, which compared cyclophosphamide-based immobilization versus G-CSF plus Plerixafor mobilization, their median age was 61-62 years. Our median cohort age was 48 years. Similar to them, we also showed that total CD34 dose was higher in the cyclophosphamide chemobilization groups in comparison to the other groups. Their primary endpoint showed a better efficacy for the cyclophosphamide mobilization groups. However, importantly, in our group, group 2, that is G-CSF plus Plerixafor, was comparable to the 4th group, that is cyclophosphamide plus G-CSF, with respect to the primary endpoint. Mobilization failure was comparable in all the 4 groups. Our limitations include it is an inherent bias of retrospective analysis. It is done over a 15-year period with changes in induction regimens and availability of medicines like LEN and generic Plerixafor. And I'm yet to complete analysis of grade 3, grade 4 adverse events and the cost. To conclude, cyclophosphamide-based chemobilization regimens have advantage of a higher total stem cell yield. However, they are equivalent to G-CSF plus Plerixafor for harvest in a single apheresis. If we add bortezomib to cyclophosphamide, it may help to increase the stem cell yield, but bortezomib plus G-CSF is an inferior regimen. Thank you.
So very good work again. So, if we were to ask you what would be your choice for the next patient, what would you do?
GCSF plus plerixafor. If he fails, then bot side GCSF.
Thank you.
Nice presentation. The 19% of the patients in the board side GCSF ended up getting plerixafor. If we exclude that 19% of patients, what is the median CD34 collection?
I haven't looked at that.
It's possible some of the data may have been skewed by the fact that significantly higher number of patients actually ended up getting plerixafor based on the peripheral blood CD34.
So 20% did receive plerixafor, 80% did not receive.
Right.
So I presume it may not be that skewed, but I'm yet to analyze that.
Status you use for p-value because it looks like you use t-test for 1 and 2, group 1 and 2 and 2 and 3 and 3 and 4. Is
The
that
Kruskal-Wallis test was used for the quantitative data in all the 4 groups. Kruskal-Wallis test.
okay?
Excellent work. 2 queries in continuation to what Dr. Shaji asked. So, how did you negate the effect of plerixafor statistically? Because certain patients received plerixafor based on the peripheral CD34. Second point, based on the same point, shouldn't your endpoint be, rather than the CD34 count of the stem cells in the first day harvest, it should have been the peripheral CD34 on day 4 or day 5 early morning. So that would have been a better endpoint rather than looking at the harvest, because harvest CD34 would have got changed by the use of plerixafor in certain percentage of patients.
So I did look at, I'll go back from the second question. I did look at the peripheral blood CD34 on the day of mobilization and 1 day prior to that. When we look at all the 4 groups, the peripheral blood CD34 on day 4 in group 1 and group 2 was 21 in group 1 and 13 in group 2. Now the issue is, as a clinician, there is a bias wherein we chose patients in the BOT GCSF group where we thought that maybe they will not fail, and the GCSF plus plerixafor group wherein we felt that he has received radiotherapy, he has received a bit more length, so he should be put in that group. When we compare the day 4 and day 5 kinetics of BOT GCSF and GCSF plus plerixafor, in the day 4 and day 5, the difference in the BOT GCSF was from 18 to 32, which means the median drive was only 14. From 21 to 32, median drive was only 12. In the second group, the median rise was from 13 to 41, which means that plerixafor is much better with respect to the increase in CD34 on day 5 in comparison to bortezomib. That was one, but I did not put that because there was a bias in choosing patients in the group 1. And the first question was?
How did you negate the effect of plerixafor statistically? So there is something known as a subtraction analysis. So did you do that to just negate the effect of plerixafor wherever they received as a IPS?
I'm sorry, I haven't done that.
Thank you all the judges and participants for the successful conduct of this oral presentation.
A very good morning to all. We are thrilled to have you join us on day 3 of the 5th annual meet of the Indian Myeloma Group. We begin with our CME talks for the day. Our chairpersons are Dr. Narayan Kuti Warrior and Dr. Prantar Chakrabarti. Dr. Narayan Kuti is Medical Director and Senior Consultant at MVR Cancer Center and Research Institute, Calicut. Dr. Prantar is Director, Hematology and BMT at AMRI Hospital, Kolkata. I invite our chairpersons to the dais to introduce the speakers.
Good morning everyone, and happy Pongal and Magara Sankranti to all. This session is basically we all are looking forward newer directions in multiple myeloma. The first speaker is
none other than Nupur Raj, and she doesn't require any introduction. Over to Dr. Nupur.
Good morning and thank you very much. What I will be talking about in the next few minutes is the immune system, immune reconstitution, and vaccination. And I think these are really incredibly important topics in the context of myeloma, specifically given that we are living through a pandemic. The pandemic is still not over. And second is, with all of the fantastic immunotherapies that you've been hearing about, I think the impact on using our immune system to the best possible capacity is critical. And for that, understanding the immune system is equally important. Here are my disclosures. And really, as mentioned, we live in a very fortunate space in multiple myeloma. We've seen a tremendous amount of progress, and despite the fact that we've had a pandemic for the last 3 years, we've actually had 3 immunotherapeutic strategies approved. We've had 2 CAR T cells, and we've had a first-in-class bispecific T cell engager, as well as an antibody drug conjugate approved in the last 4 years for myeloma. So incredible progress, but with this progress, I think it comes understanding some of the toxicities, understanding how best to manage these patients is important, and to do that, understanding our immune system is important. So the immune system is not something which is new to an oncologist. This is something we've studied for many, many, many years, and T cell energy has been a very important part of why people, specific people, end up developing cancers, and not everybody else develops cancers. And I think it's critically important to myeloma, given that it's an immune, so it's a cancer of the one of the immune cells, which is the plasma cell. So understanding this is important as well. Again, there's a lot of parallels that one can draw from the cancer world and from the infection world, and specifically chronic infections, where you will see T cell exhaustion patterns, impacts on CD4, CD8 cells, and some of the T regulatory cells as well, which we'll try and put in the context of myeloma. Now, with this, obviously, there is a risk for infection, and that risk of infection is it's changed over the times, and in the context of novel therapies, it's important for us to understand. And this is data from, it's almost like a registry data, looking at patients without cancer, and then patients with cancer, and then patients with different in different cohorts based on different treatments. So the risk of infection hasn't gone away. It's just that the risk of infection over time, depending on what kind of treatment you're getting, that risk changes. And that's something we're going to talk a little bit about. I'm not going to go into too much of detail on infection, because I do know there's a separate talk on how do you treat these infections in this context. And why is this important? This is important because obviously people are still dying from infectious causes, and specifically so in the cancer world, these mortality from infection is not trivial. So again, when you think about immunosuppression, and now focusing more on myeloma, the spectrum is from minimal immune suppression, and one can have severe, significant immune suppression. And we have this precursor disease state of MGUS and smoldering myeloma, where the immune system is fairly intact, whereas severe is where you're using high doses of chemotherapy, or you're using sort of myeloablative chemotherapy. And even in the relapse refractory setting, with some of the treatments that we have, you can end up with severe immune compromise. It could be disease related, and it could be treatment related, and it could be a combination of the two, and I think it's important for us to understand that as well. So just a few words on the immune system in general, and specifically in myeloma as well. Within the immune system, you have cells which are tumor promoting cells, so the myeloid-derived suppressor cells, for example, regulatory cells, the plasmacytic dendritic cells, and there's more and more preclinical work on all of these tumor promoting cells. There is obviously data with the anti-tumor cellular immunity, and this is something which we really used and honed in on to try and develop some of the novel treatment strategies, including with, and you will hear more about things like NK cells, where we're doing CAR T cells with NK cells as well now. So again, impaired and deregulated T cell immunity is obviously seen in multiple myeloma. It's actually seen very early in the precursor disease states of smoldering myeloma also. And I think we've studied the precursor diseases quite a lot in the context of the tumor cell itself. But now there's more and more data looking at the microenvironment and specifically the immune system as to this being a risk factor for the progression of developing myeloma. So understanding the effect on cytotoxic T cells, understanding the effect on exhaustion of these T cells is really important in terms of biology of myeloma and progression to more aggressive forms of myeloma, and also when it comes to using some of the treatments that we have for this disease with respect to anti-tumor effect of this immune system. So when you think about the function of immune system, you can kind of divide it up. You can have T cell exhaustion that could be disease related or treatment related, T cell energy that could be baseline and also treatment related, and over time, and also given that our disease is a disease of the older patient population, we do from treatment as well as from age and other comorbidities can see T cell senescence, which impacts the risk of infections in this patient population. So you have all of these competing things, T cell dysfunction, which we do see in the context of the bone marrow microenvironment, more so when patients have active disease. So the best way to counter that is control of the disease course is really important. And as patients get multiply relapsed, you will see that their T cells tend to get exhausted, and that's part of the reason why when we talked yesterday, moving some of these immunotherapeutic strategies earlier may be of benefit. Differential T cell profiles have been noted, and this has been looked at in the context of prognosis from a disease standpoint and also from the risk of progression from these precursor disease states to active disease. So why is all of this important? It's important because we are also in the context of drugs. I showed you that timeline of drugs, and we talked a lot about drugs like daratumumab yesterday. And we do see the effects of daratumumab on the immune system or any CD38 monoclonal antibody. Example I've used is daratumumab. You're going to see the same effects with isatuximab because CD38 is expressed not just on the myeloma cells, it's expressed on the T cells as well. And what you see in patients who are on drugs for protracted periods of time with daratumumab is a low absolute lymphocyte count. I think this is important specifically if you're thinking about doing cellular therapies or bispecific T-cell engager therapy post drugs like CD38 antibodies. We see decrease in CD4 cells, and what we have seen is different types of infections. We've seen viral infections, bacterial infections, and also fungal and parasitic infections which were not being seen in the recent past have now started re-emerging in the context of some of these drugs. Similarly, we have a lot of work which we are doing using BCMA-directed strategies. Now, BCMA is a protein which is expressed on all plasma cells, and plasma cells we know are antibody-producing cells. So it's a very important part of your immune system, and when you're targeting this, you're getting rid of that immune response in these patients. So if you look at some of the data now, and this is data from the IDACEL Karma study. If you look at data from here, these patients in the immediate phase can have neutropenia, thrombocytopenia, and the risk of infection, although not very high, any grade was about 70%, grade 4 was quite low, but these patients can be prone, at least in the first month post-CAR T cells, to these infectious complications. Similarly, with cilta-cel also we've seen very similar data, and in fact with bispecific T-cell engagers the story is very different. Here I've just picked teclistamab only because this is the one which is now approved in the United States, and the difference here is because we are giving this chronically and continuously, we did see a rate of any grade of infection of about 76%, and the rate of grade 3 and grade 4 much higher than with cellular therapy, so grade 3 and 4. Granted that we were using these drug products in the height of the pandemic, we saw a lot of COVID-related deaths using bispecifics, but even so, we are seeing sort of different kinds of infections when we're using these bispecific T-cell engagers, and one of the reasons for those would be constantly engaging the T-cell and causing exhaustion may be predisposing to these different infections. So infection prophylaxis is really critical in our myeloma patients, and to prophylax these patients, I think it's important to risk stratify patients, and therefore having a basic understanding of the underlying disease, comorbidities, and what is the treatment that you're giving, as well as any predisposing genetic factors a patient might have, is critically important. And infection prophylaxis cannot necessarily be one size fits all, but one would have to do it different for different patients. In terms of vaccination in myeloma, I think again a really, really important topic, and it's a topic which our primary care physicians always want to know exactly what to do. And the issue with vaccination in myeloma, so the problem here is we do not have good data. We do not have good prospective studies with vaccination. What we do know though is that vaccination cannot do harm. We do not know whether it can absolutely benefit a patient, because depending on the disease state of a patient, whether or not a patient will mount an immune response remains a question. But vaccination is important, and not just vaccination of the patient, but vaccination of close contacts is also critically important. I think there are a few principles that you can go by. One is obviously you want to avoid live vaccines, and I've just listed those. We do have a new zoster vaccine now, and that Shingrix, we call it Shingrix in the US, that can be used in patients with myeloma. The old Zostavax was not allowed to be used, and some of these live vaccines should not be used. In terms of precursor disease states like MGUS and smoldering myeloma who are not being treated, they should be almost considered as normal individuals, and they can be vaccinated without problems. Again, principles of vaccination, as I've already mentioned, all myeloma patients should be vaccinated. Vaccination of close contacts so that you avoid the risk of infection in the patient themselves. We do vaccinate for the flu, and what we've started doing based on studies which Andy Brannigan from our group has done using the flu vaccine, wherein instead of giving just one dose, the study here, his study was called the Shivering Trial, an apt name for a vaccination study, but what he showed very nicely was with one dose of the flu shot you mount an immune response, but when you get a second dose of that flu shot, at least in myeloma patients, the immune response was a little bit higher. So what we've started doing at MGH at least is when flu season starts, October, we give them their first shot, and then we repeat a second shot of the high dose flu shot sometime in January or so, and this is part of our new guidelines. Pneumococcal vaccine is recommended. We give both Prevnar as well as the other pneumococcal vaccine in patients. This is just a list of all the vaccinations. So pneumococcus should be given to all patients above the age of 65, and in fact anybody who has myeloma giving them the pneumococcal vaccine is important. I've already talked about the flu shot and these others, meningococcal tetanus, DPT, and post-transplant actually, once you've had a transplant, 6 months post-transplant, we need to revaccinate. Similarly, once patients have had CAR T cells, we wait, instead of 6 months, we wait for about 3 months, and post 3 months, we start revaccinating them post some of these treatments as well. This is just highlighting which vaccine should be given and how often should patients be given this. So when does one vaccinate? Again, really important question and practical. So for you, again, you have to individualize and you have to look at the risks and benefits of when you can vaccinate. In general, things like the flu shot, you just give it to them every year. It doesn't matter what their disease state is. The one caveat is you don't know for sure that it's going to work in patients who have very active newly diagnosed disease or relapsed disease. If a patient is actively getting chemotherapy, we try and time the vaccination a little bit away. Specifically in patients now, we don't use as much chemo, but if they're getting drugs like daratumumab, and if they finish their weekly DARA and getting it, say, once a month, we do it sort of week 3. So you can pick a time to try and optimize the use of that vaccination depending on what kind of treatment you're using in a patient. Do we assess serological responses in myeloma patients? And the answer to that is not. We do not. And the reason for that is it's an expensive test. And even if they didn't mount a serological response, would you not vaccinate a patient? Because serological response is just one arm of the immune system. There's a whole T cell component to that immune system, and you're really not measuring that by just measuring serology. So typically we don't do it. In certain situations, when you do a clinical study, for example, we've studied it like Andy did it in his flu vaccination trial, but generally looking for serological response is not recommended. We've done it with COVID-19, and I'll show you some of the data here. But again, as mentioned, I think risk-adapted infection prophylaxis is key. Trying to identify where your patient falls, low, intermediate, or high risk, depending on what level of immunosuppression, disease status, and what kind of treatment they're getting, then you can come up with your bacterial, fungal, or viral prophylaxis. In general, I think most of our patients are on antiviral prophylaxis, so everybody almost always gets acyclovir or its equivalent. A lot of our patients now, we've started putting, I never used to use a whole lot of PJP prophylaxis, but after using some of these bispecifics and things like that, I think I've started using PJP prophylaxis more so now. I didn't used to use it. And the last one is fungal prophylaxis. Typically, most of our myeloma patients don't need it, except if you see prolonged neutropenia. And with some of the bispecific T-cell engagers, we are seeing that, and we are incorporating even antifungal prophylaxis. I think a really important point, specifically when we're using B-cell directed strategies, like these anti-BCMA directed strategies, is immunoglobulin replacement. So we typically see IgG levels of these patients, and a lot of them will have immunoglobulins less than 400. And these are patients where we have been pretty proactive about replacing them with IVIG. With that, we are seeing a lower incidence of infections. Immunoglobulin replacement could be intravenous. You could even do the subcutaneous version, and we, at least in the US, have home IVIG programs that we can use, and we are tending to use more of this in the last several years with COVID and with some of the B-cell directed strategies that we are using. I think this I've already talked to you about, bacterial, fungal, and viral prophylaxis. So last few minutes I'm going to spend on COVID-19. We've all been through sort of an incredible time in the last 3 years, but the good news is we've learned a lot. We've gotten several vaccines which are approved and in record time. And in addition, we have not just different antiviral drugs, but we also have antibody therapies which have been tried and have been somewhat useful in some patients. So these are just the common symptoms. I think all of you are familiar. I think all of us have seen our patients go through this. We are physically have gone through it ourselves as well. And does it make a difference between cancer and do patients who get COVID-19 and cancer do worse? And the answer to that, compared to the normal population, obviously our patient population is more immunocompromised. So yes, they do worse, but what about COVID-19 and myeloma? And the International Myeloma Society under Nikhil's leadership actually did a lot of work early on with COVID-19, where we were seeing a lot of infections in patients with myeloma. And what we saw, interestingly, was that the mortality was a little bit different based on countries, and it could be related to the kinds of treatment they were getting, as well as vaccination strategies as well. I think all of that has changed. We did see a lot more mortality. Even within the US, we saw regional differences. For example, the New York state and New York City had the highest level of mortality compared to the rest of US, because that was the hot spot. So this was sort of different in different parts of the country. And from that data, I think what we ended up doing was learning what the risk factors were. And I think the biggest takeaway for us was that the most important thing was patients who are in a remission actually ended up doing well, outside of all the comorbidities. So what is controllable is control of the disease. And in the early days of the pandemic, the thought was, let's stop treatment, let's not see these patients. But the critical piece was controlling that disease and making sure your myeloma patient is in remission would afford them the best outcome from infections from COVID-19 as well. So as I've already mentioned, a lot of bodies helped in this effort, but the IMS was really critical in us trying to come up with an approach to our patients with patient educations and trying to control and making sure that our patients got vaccinated. The IMS did come up with recommendations in the setting of this pandemic, and I think it was really the biggest thing was prevention. Biggest piece was controlling myeloma, and finally vaccinating everybody depending on whatever the vaccine available at that particular place and whatever the recommendations of institutional guidelines had to be used. So the good news is we've had lots of different vaccines. India has been at the forefront of actually producing vaccines as well. You know, your next image meeting is in Pune, and Pune has been critical in producing vaccines for the rest of the world actually. What we've used is mRNA-based vaccines, so mostly Pfizer and Moderna was used in the United States, but I know here you had other vaccines available like the AstraZeneca vaccine. So it didn't matter which vaccine as long as you ended up getting vaccinated. And these are some of the vaccines which have been approved based on phase 3 trials for COVID-19. Infectious Disease Society in America has come up with guidelines. These guidelines keep changing, and the guidelines keep changing because this has been moving so quickly. So for example, right now, if we had somebody we have drugs, we have vaccines, and we have antibodies. For drugs, if you have somebody who's COVID-19 positive but not requiring oxygen and can be treated at home, we're using an antiviral called Paxlovid. If a patient has COVID-19 and is oxygen requiring and needs hospitalization, we're using 5 to 10 days of remdesivir. And if they are oxygen requiring, in addition to remdesivir, we are adding dexamethasone. Obviously, everybody is getting vaccinated using drugs like Evusheld. Evusheld was an antibody. It's not that effective with the new COVID variant, because remember, Evusheld was made from the old people who were infected, so they weren't exposed to the new variant. So this is a rapidly moving phase, but this is specifically Evusheld, at least in my experience, has been incredibly important in patients of ours who have Waldenstrom's, for example, who've been on long-term rituximab, and no matter how many vaccine doses you give, these folks absolutely don't mount an immune response. So using drugs like Evusheld has been really important, and in a subset of our patients, specifically post-CAR T cells, we've actually used antibodies to protect them when they couldn't get vaccination. So I think the key points for myeloma is the risk of infection is not necessarily higher, but there is infection, and it could be patients could have a poorer outcome based on the immune system. And if you don't understand this and don't understand the risk and individualize how you're going to take care of this, that can be a problem. I think controlling the disease clone is absolutely critical, and trying to minimize comorbidities. Things like renal failure, etc., makes things worse for infections. These are the ones who can become septic and actually have a worst outcome, is really important. In the setting of the pandemic, the one thing we did see in the United States when we were using masking and social distancing, so last year, not this 2023, but before 2023, our incidence of flu was really low. We started seeing an incidence of flu going up because none of us mask anymore, but masking and social distancing actually did make a difference. And in general, vaccines are very safe. Whether or not they're effective is a debatable topic, and that's why, given that they are safe, I think our recommendations all round, as long as it's not a live vaccine, should be given to all. So I'm just going to conclude by saying the risk of infection is therapy dependent, so understanding that is important. It has to be risk adapted, what kind of prophylaxis you use. We do use, when you see prolonged neutropenia, thrombocytopenia, using growth factor support is critical. Using IVIG is important, and vaccinating everybody is actually critical. What are the unanswered questions? Well, there's not a lot of prospective data in this space, so trying to do that would be good. From a research standpoint, immune monitoring is becoming incredibly important, not just in terms of response to treatment, but also progression of disease. It is critically important looking at this microenvironmental piece, and that's something which is being done in the research setting. And again, lack of data on immunization does exist, and we just use best practice to come up with ideas. So I'll stop here and happy to answer any questions. Thank you.
Yeah, you can ask your questions, please. One or two. Pankaj.
Yeah, so nice talk again. So I did not get it clearly. We have the habit of vaccinating, at the time of diagnosis. What I gather from the talk is that we hold on till they get into remission. I was,
So
not
when
sure.
they're in remission, your response to a vaccination is going to be better.
Yeah.
There's data when they're on an immunomodulatory drug that your immune responses are going to be better. But in general, for pneumococcal vaccine, we typically will do it at the time of vaccination. Whether you want to revaccinate when in remission, that may be a good thought. But otherwise, all other vaccinations, hopefully doing them in remission, they're going to have a better chance of a response.
Yeah, because in India the patients present quite late, and most of the patients come with infection, and we have seen that in the first 3 months the mortality is quite high in this patient, up to 20%, and by doing vaccination at the time of diagnosis, at least we can reduce some of these infections. Though we need to vaccinate again, yes, you.
So do you all do routine sort of antibacterial prophylaxis to try and...
No antibacterial, but patients who are on renal failure and receiving high dose DEX, they generally are put on PCG as well as antifungal prophylaxis till the time they are on high dose DEX.
Do you recommend routine here? Yes, sir. Do you recommend routine estimation of immunoglobulins, and if so, how often you do it?
So immunoglobulins we're usually measuring in any case to look at response to treatment. So monthly SPEPs are routinely being done. So when we start seeing IgG levels go down, we typically never used to. With the B cell directed strategies, I think we have become more proactive about using IVIG. But in general, I think we measure that in any case.
I had a question actually for Pankaj and others, that what do you do specifically for tuberculosis prevention pre-post transplant, or do you look for it?
This is very interesting that, you know, every forum actually people ask about the tuberculosis. Somehow in all these patients we have not seen a very high incidence of tuberculosis. Maybe, you know, once they are diagnosed, they are kind of in a protected environment and they are taking precautions and they are not in the community. Probably that may be the reason, but we have not seen a high activation rate of tuberculosis, whether it's a transplant patients or whether they are myeloma patients.
Yeah. But the only reason I asked, I had two patients from India, two of those, who actually came for treatment and transplant, and one of them had a resistant tuberculosis developed pre-transplant, and actually we couldn't do transplant. The second one was prophylactically treated soon after, and so 2 out of some sounded like a high number to worry about.
But I think, yeah,
we are afraid of it, but I don't know, we are fortunate we don't see it, because we are monitoring them and we are always, most of them have already had it, something protects them, we don't know.
I think probably that we have a good screening technique. Pre-transplant, most of us will do CT scans, chest CT and everything, and maybe we screen them out for the transplant. But even in the pre-screening things, we hardly find any patient with the tuberculosis. In our database of across in the image database of transplant, we don't have a single patient with tuberculosis.
Just to add to that, in even other malignancies and other hematological malignancies, we did some study when it was at Tata Hospital to see whether there's an increased reactivation while on treatment. No, we didn't.
And if patients have had TB and then you're going to treat them, do you put them on low doses of anti-TB medications?
No.
Once treated,
no.
It's fine.
We do not use any INH prophylaxis or anything.
Yeah, and if there are, let's say, you know, the CT scan does show that there are some infiltrates or something like that. So then if we are to give prophylaxis, then it is both rifampicin and INH, because the INH resistance is approximately 20% or so. So there you have to recommend 2 drug combination.
Thank you. Thank you. So now it's my pleasure to invite Professor Atul Sharma. I don't think he needs an introduction, but he is at ISH AIMS New Delhi, and he will tell us what is new and are we there for targeted therapy. So, yeah.
Good morning. Thank you, Hari, for this invitation. Probably the topic is target therapy in myeloma, whether are we there or not. So I'll take back you to the history for many, many decades. If you see the history for myeloma in last 100 years or so, far more discoveries and understanding has been done in last 25 years. But this doesn't mean that there was none in the previously. Last 70 years prior to that probably laid a strong foundation on which last 25 years discovery have been made. So if you see, more number of drugs were investigated or discovered in last 25 years. When I started my career in this oncology, probably sometime early 90s, we were taught the median survival of myeloma patient is really close to 2.5 to 3 years at the max. Transplant was just introduced in this thing. So this cartoon shows you that how we made a progress in last 25 years. If you see really from the 2000 to 2022, there is almost doubling of the median overall survival, but we learned that there are the centers in the US and elsewhere where the median survival may be close to 8 to 10 years or so, even in high-risk myeloma, this thing. So when we started in 1990, it was 2.5 to 3 years. Now more than 60% of the patients will be surviving 5 years with the available treatment. If you see the natural history of multiple myeloma, what happens is the patient present with symptomatic disease, ambient and this thing, you started them on some kind of the frontline treatment, induced them, consolidated with the transplant, and thereafter you put them on maintenance. Over a period of time, maybe 18 to 20 months later, they will probably again relapse. You start them on the second line treatment, they do get some kind of the response, and again they only to relapse further, and you subsequently treat them with the third and subsequent line of treatment, and we have the fourth, fifth line of treatment nowadays available to our patient. What has made these changes? Initially they were in 2011, the genomic sequencing was first reported for myeloma, and subsequently based on the IFM study and we have the more and more understanding of the mechanism of myeloma. This is expanding, and this we are also come to know about the potential molecular drivers myeloma, and this is helping us in getting more and more targeted agents for the myeloma. This cartoon shows the probably possible mechanism of the various drugs and the antigens or receptors expressed on the myeloma cells. It simply says that probably you have the drugs available to most of this. We have the IMiDs, which was started in 1999. They add through they act on the cells. Then we have the antibodies, then which are probably CD38. We have the CD138. We have the proteasome inhibitors, which probably are in routine clinical practice, acting on this thing. We have the drugs acting on the ribosomes, inside the ribosome, and probably we have the newest one is the CAR T cell, BCMA, and so on. And I'm sure Hari is going to discuss more about these agents. So these are the few phase 3 studies using the monoclonal antibodies in myeloma. I'm not going into the details. You directly heard from the horses of the mouth. We have the lead expert sitting here, or many of these people, they have led many of these studies and this thing. What I'm trying to say, this slide shows that these are the various studies. They have been the transplant ineligible and transplant eligible subjects. It also shows the control and study arm, number of patients enrolled in these studies, what are the overall response and complete responses, median progression-free survival, followed by the hazard ratios and this thing. Lastly, also we are nowadays talking about the MRD negativity, and consistently if you see this slide, you will find that of course we are getting the response in excess of 90% with many of these molecules or drugs. We are getting progression-free survival about little over 3 years, and almost all the studies has shown there the improvement as responses, median PFS, and also MRD negativity, except the SWOG trial and the equivalent trials which use the elotuzumab. So these are some of the studies using the monoclonal antibodies in relapsed refractory multiple myeloma. Again, you are seeing that the responses may be in excess of 80%, and the median PFS may be 1.5 to 2 years and this thing. And also we get about MRD negativity in about 10 to 15% of these subjects. Would like to just update the data from the Griffin basic trial. We now have the probably, if you see that this next gen flow 10 raised to power minus 5 and 6, about 64% of these patients will be getting the good MRD negativity, including the 10 raised to power minus 6 compared to this thing using the monoclonal antibody compared to without that. Again, you see the PFS is in the range 4-year PFS more close to 89%, 87%. Usually this probably wasn't the case in 20-30 years ago. So this is the progress we have made. So with regard to the monoclonal antibodies, are we there yet? Yes, there have been a lot of development in the recent past. Near molecular targeting the CD38 antigens and a better understanding of DARA resistance is crucial to further these studies or get the further benefit out of these molecules. We may probably will be able to augment CD38 antigen targeting by epigenetic modifications, and cost is a big issue, of course. For the time being, not most of our patients will be able to afford these agents. This slide was earlier discussed a while ago. Probably the BCMA in multiple myeloma. This is a target for either the CAR T cells, bispecific T cell engagers, bispecific antibodies, and ADCs also, and I'm sure Hari will be touching base with these in little detail. So again, you can have the BCMA antigens expressed on the myeloma cells, which can be targeted by the ADCs, CAR T cells, and bispecific antibodies. So this is one of the new ADC, which is probably recent development in the myeloma. You have this thing, belamaf. It can be targeted. This is so molecule BCMA expressed on the myeloma cells can be targeted. So drug is internalized. This thing and monomethyl, this thing auristatin F is probably internalized, released into the in the cells, and probably help in the proteolytic. This is a microtubule act on the microtubules. So some of the data again further this thing, belamaf, probably using the 2.5. This trial was led by Sagar Lonial. Probably we have the data from using the 2.5 milligram per kg body weight given every 3 weeks, little close to 100 subjects. And if you see, these are heavily pre-treated patients, and if you see the outcome, the duration of response is about 13 months, and the patient who responded either had the minimal or partial response. Their survival appears to be superior to those who did not. Vast majority of the patients, about a third of patients responded to this particular drug. Again, this was a question yesterday in the quiz program. Keratopathy is one of the common side effects of this. And these are the few of the ongoing studies using the belamaf. So this is something new, which is BCMA targeted antibody drug conjugate, MEDI 2228 study. Probably this is a fully humanized anti-BCMA antibody, which is conjugated to again a DNA cross-linking agent, pyrrolobenzodiazepine. And after in a while, probably now we will be hearing about the CAR T cells, so I'm not going into the details. This thing, we have the lead investigator sitting right here. Probably these are the different doses of a CAR T cell used in this particular the CAR T cells, and you see that the responses are excellent. Not only this, the response is very likely to be durable also. If you see the PFS by the target dose on this thing, or best response, the patient who had the good response there, the PFS is likely to be much better than the other agents, other patient. We have the two, there's the Siltacap and the thing that was IDCAP. So we are getting the response is with this particular CAR T cell with almost every patient. So these are the survival curve for the relapse refractory multiple myeloma using the CAR T cells, excellent responses. And if you really compare the different CAR T studies or the cell directed treatment, you find that most of them, they were selected the patient who are absolutely refractory to most of the available agents, sometime maybe the 5, 6 or 7 prior protocols, and the responses are 70 to 80 to 90%, and many of these patients probably will be having a durable long-term survival also. The problem with the CAR T cell, again, probably I'm not going to in detail, is that probably we need to have to select patient carefully. There need to be widespread availability of the CAR T cells, and probably adult responses, relapse also, though uncommon, is not is always there. Chances of relapse is always there. We have this thing again, the bispecific T cell antibodies myeloma. Hari is going to speak on that, so I'm not going into the detail. So there are a lot of clinical studies which have been completed using the bispecific antibodies. Probably we have some of these agents were discussed earlier. What is the highlight of these bispecific antibodies? That we continue to get the responses within the refractory cases, and some of these may be durable of this thing. So this slide compares the various cell directed treatment, CAR T cell bispecific and antibody drug conjugates. There are certain differences between these two. So we can have the ADC and bispecific anti off the shelf, but we need to have the personalized CAR T cells. Probably the single infusion is the advantage with the CAR T cells, where probably The other disadvantage CAR T cell is that probably you need to leukodeplete using the cyclophosphamide and agents and fludarabine. So targeting BCMA, this is one of the effective way to eliminate malignant plasma cells. Probably we have the unprecedented phase 1 and phase 2 data, seeing the response in excess of 90%. Duration of response is unless we are far, but we are waiting for the long-term data from the CAR T cell, but probably it may be durable responses like we see many times in acute lymphoblastic leukemia. So we have the bridging therapies forward. Why wait for the exhausted T cells? We have the newer molecule also, which undergoing clinical trial. If you word about the venetoclax, mainly with regard to the BCL, those who have the T1114 and BCL2 overexpression. This is a trial led by the Shaji. Probably it's a selective orally available small molecule. We are using in the thing, acute AML and the CLL also, but now also in the myeloma with the subset of the patient who overexpress BCL2 or have 1114. Good number of the responses has been shown. This is one of the trial, Bellany trial, using the venetoclax, bortezomib and dexamethasone, and it has shown the responses in the patients, response in the patient who had 1114 translocation, were significantly higher than those who did not, and so was the progression-free survival. This is a new drug, again the selective inhibitor of nuclear export, and we have some data for use in the relapsed refractory myeloma, having responses in about 26% of the subjects who receive this in refractory disease. And there are a number of trials using the combining this with other agents, available target agents approved in the multiple myeloma, getting responses about 30 to 40% of these patients. So coming to the end, so target therapy in myeloma, are we there? Yes. Probably we are making a small headway. We are not close to the finishing line. Novel therapies definitely are providing deep and durable response in relapsed refractory myeloma. There is no cure yet. I'm sure Dr. Nikhil Munshi is going to speak about curing the myeloma. There are rational strategies for sequences is needed. Bringing novel therapies to earlier lines will drive FDA approval by MRD response, and east or west probably test is the cost. So we need to have bring the cost cut down for number of whether we are in the eastern side of the hemisphere or the western side. Cost is issue everywhere. With that, I would like to stop here. Thank you very much for patient hearing.
Yeah, are there any questions? Atul, Atul, are you using any of these drugs in the later lines, like when all the therapies are exhausted and the patient is willing to pay in sort of a situation?
So, say that again.
Are you using this newer antibodies? Have you ever tried any?
So we have used as a CD30 or DARA we have used.
Other than that?
Yeah, other than that I haven't personally.
Well, nice presentation. Are you able to use venetoclax at all in the 11-14 patients?
No, we haven't used it.
Is it commercially available easily?
Venetoclax? Yes. So what we are getting, we are importing from. It's not generic. Is not available.
Generic.
No. So we are importing, and nowadays we are getting a lot of the drugs being made in Bangladesh.
Grey market.
So it is coming as one of the factory for this.
Yeah, recently Bhutan is not governed by many of the patent laws, so many of the companies are doing manufacturing over there, and so now venetoclax is one of the companies, not naming it, but has come out with 20,000 rupees a month.
We get mainly from the Singapore.
Bangladesh, Sri Lanka, Bhutan.
So Bangladesh will be generic, but original molecule will be from the Singapore is the one.
Yeah.
You can prescribe it. And
yeah, we can.
at a personal level.
Yes, because it is not licensed by DCGI.
Yeah.
Okay, thank you,
All
Professor
right.
Sharma.
Thank you.
And now we can invite the organizing person who will tell us all about T cell directed therapy and when we bite the plasma cells.
Thank you. Can I have the slides? So I'll be very specific to my talk, and to give a talk on something that you have not much of an experience in is a little bit of a difficulty. But anyway, the topic is on bispecific antibodies in the treatment of myeloma. As a default comment, yesterday we had this comment from our international experts that probably when we have CAR T cells with us, probably bispecific antibodies are not going to catch up as much as we wanted to, but it may be relevant in the Indian setup, where if there are those people who can really afford, maybe as a stopgap, to try and control the disease. So I start with this slide, and I start with the left-hand side of the slide, where we know that despite many advances, it's a real challenge to treat relapsed refractory disease. And much of the treatment has been moving towards trying to find solutions to deal with this condition, because the median survival is less than 6 months in multiply relapsed multiple myeloma. One of the things that has been the toast of the last 6 to 7 years has been immunotherapies, immunotherapeutic approaches, and to harness the immune system for anti-tumor effect. And the three aspects to this has been the use of chimeric antigen receptors, which I will not discuss about. We have a separate session on that, and the antibody drug conjugates, which has come actually earlier than many of the bispecific antibodies, and of course the bispecific antibodies. So why bispecific antibodies? And just to have an idea, there are different forms of bispecific antibodies that you can that we have, and bispecific antibodies basically are engagers. They bring the immune effector cells in proximity to the specific antigen expressing myeloma cell to promote direct cell mediated cytotoxicity. And they ideally have an FC portion, and this FC portion actually provides a great deal of stability and a longer half-life for these antibodies. But there are antibodies also that lack the FC, and but the difficulty with these antibodies, they have to be given as a continuous infusion because they have a short life, and one of the examples is probably blinatumomab, which we use for treating acute lymphatic leukemia. And then you have the trispecific antibodies, where the targeting of an immune effector cell and with two distinct myeloma antigens, or on the other side you have trispecific antibodies with co-stimulatory molecules, which is like the T cell or the NK T cell antigen 1 and 2, and these are the different forms of bispecific antibodies that you use for treating, and when we, let us say over here, multiple myeloma. And this is the slide which I have borrowed from Shaji's online CCO, which looks at the various aspects, various strategies that we can employ, and that is CAR T cells. You have the bispecific T cell engagers and the bispecific antibodies, and also the antibody drug conjugates. Basically, it is bringing the immune effector cell in proximity, and also in the case of antibody drug conjugate, you are releasing the payload into the cell for cytotoxicity. So what is the objective of treating bispecific antibodies with using bispecific antibodies is to maximize the benefit and minimize toxicity. We do encounter many of the side effects that we see with chimeric with CAR T cell therapy, which is mimicked by the bispecific antibodies too, but to varying different extent. And you have targeting antigens that are unique and specific to multiple myeloma. And in this cartoon, what we see are the various antigens that can be targeted, and the ones that are in dark are ones that have already been in clinical use, and the others are sort of being evolved as targets for the bispecific antibodies. But currently we have mainly 4 targets in clinical trials. That is BCMA, the CD38, the GPRC5D, and the FCRH5. So why BCMA is a target? Well, it's a type 3 transmembrane glycoprotein, which is associated with tumor necrosis factor receptor superfamily, and they function to regulate the B cell proliferation, its maturation, its survival, and also differentiation to plasma cells. And it binds to ligands, a proliferation inducing ligand, APRIL, and also the B cell, or the BAF as we call it, the B cell activating factor. And APRIL and BAF signaling via the BCMA are essential for humoral immunity, and blocking this interaction prevents antibody formation. And when we use these as BCMA as target, because they are expressed on all plasma cells and selectively more in malignant plasma cells, you have a good target over there to use a bispecific antibody to target this antigen. So BCMA targeting bispecific antibodies in relapsed refractory myeloma, there have been mainly 4, and the ones that have been published now is teclistamab, and we have phase 1 data on elranatamab, the REGN5458, and the ABBV383, wherein which varying response rates which are more or less comparable, ranging somewhere close between 60 to 72%. You do have, except for the REG1, where the CRS rates are probably about the same, with some differentials in the neurotoxicity, with teclistamab having about 3% and not being reported with elranatamab, and infection rates being rather significant with teclistamab and lesser, but these are all phase 1 data. So, so we have teclistamab and the MajesTEC-1 study, which was published in the New England Journal recently, not so recently, but last year. But last year is not too far away. Yeah. So the MajesTEC-1 phase 1/2 study of teclistamab for relapsed refractory myeloma, and it did show efficacy. There was a 26% response, and 26% of these patients were high-risk cytogenetic patients, and 77% were triple-class refractory, and 18 close to 90% were refractory to the last therapy that they received. There was an overall response rate of about 63% in these patients, with CR being achieved in about 32%. When we looked at the progression-free survival and overall survival, it is pretty impressive in terms of in terms of the responses that we achieve, and these we must understand were more than 3 to 4 lines of therapy which had failed in these patients. But there was also the problems that we encounter with any of these CAR T cell therapy or T cell directed therapy. I mean using the T cell the T cell for anti-myeloma effect. So you had CRS, which is about 72%, but you encountered greater than 2 grade 2 CRS events in about 33% of the patients. So the other study was the other target, which is using elranatamab for relapsed refractory myeloma, and again the overall response rates was close to around 64% in these patients. But this is a phase 1 study that we have, and we have the linker MM1 study, which again was the first in human open label phase 1 study to step up dosing of a different target for these bispecific antibodies. Similarly, the REGN 5458 for relapsed refractory myeloma, among all responses, 86% of them had very good partial response, with 43% having a CR. So there has been a gradual improvement in the response rates with and then every generation of the bispecific antibodies that have been used, but still not as close as we have with chimeric antigen receptors therapy. So can we go beyond the BCMA using novel agents? Yes, there have been. There are two drugs that are in phase 1 study and have completed the phase 1 study, which is talquetamab and cevostamab. And the target for the talquetamab has been GPRC5D and the cevostamab, which is FCRH5. And again, you experience an overall response rate of about 70%. So any of these targets seems to have a response rate of somewhere between 65 to 70%. And more or less comparable rates of CRS, of which probably the grade 2 is close to around 30%. Talquetamab, the responses were durable, and of course it deepened with time. One of the problems that I say it's a problem, yes, that was what was discussed yesterday, is to deliver this therapy every week, and it's not easy to do, and it's a continuous therapy. Whereas with CAR T-cell therapy, it's a one-time treatment, or we hope it's a one-time treatment. But so that's the way that we go with these bispecific antibodies. That can be quite a challenge, actually. But as a proof of principle, there is efficacy for the use of these bispecific antibodies. And similarly with cevostamab, which has got another target other than the BCMA, which again showed an overall response rate with two differential doses of ranging between 36% to 56%. So when you look at the safety profile of bispecific antibodies, more or less comparable. CRS is again one of the problems that we have to deal with, requiring attention, requiring hospital stay, and as we said yesterday, we probably need to garner the expertise of all our allied sciences to be able to take care of these patients when they come into the emergency. Lymphopenia was recorded in a few of these studies, not all, and immune suppression is one of the features, and as Nupur has alluded to, there are very distinctive kind of infections which we have to deal with when we treat these use these bispecific antibodies. So what about combining bispecific antibodies? And that is one of the studies with which combining with daratumumab, which is a TRIM2 study, which looked at combining teclistamab with daratumumab. There was a modest improvement in the overall response rates, close to, and over a period of time, with an increasing dose, it came up to almost 100%. But this is again in early phases of the results. But there is, and from a safety perspective, it can be something that can be utilized. What about immunoconjugates in relapsed refractory myeloma? This came up with a great lot of promise, and published in the phase 1/2 study, the phase 2 study, which was published in the in the Lancet Oncology from Lonial and group, which is looking at which looked at belantamab mafodotin in two different doses. And when you had a progression-free survival of 2.8 months, but a median duration of response that lasted as many as 11 months over here, with an overall response rate of about 32%. But the problem with belantamab has been its keratopathy, and because of which it has been withdrawn in the United States, though it's still some of the studies are still ongoing in Europe, and some of them even in India. But definitely a difficult drug to treat, and it is probably needs to be revisited. And I don't know how. And I hope it's like the gemstuzumab ozogomazin Y, where where it went out of the market for a long period of time and then made its emergence after revisiting how to deal with the toxicity of this drug. So I conclude with saying that despite significant advances in myeloma therapy, the existing anti-myeloma therapy agents are still largely ineffective for patients with high-risk relapsed refractory myeloma, but there is merit in treating these patients with these bispecific antibodies or a CAR T-cell or T-cell directed therapy. Novel targeted immunotherapies, especially bispecific antibodies, have emerged as a promising monotherapy because they are off-the-shelf therapies that can be used in these patients. And with more clinical studies showing favorable clinical efficacy, we are still learning a little bit about bispecific antibodies, how to improve and decrease the toxicity, and is there a way that we can have use these drugs for not as a continuous therapy, but a little bit more prolonged duration and sustain its efficacy for a longer period of time as against a weekly schedule. So moreover, we can expect introduction of more optimized treatment protocols incorporating these cutting-edge immunotherapeutic agents to further extend survival and to improve the quality of life in myeloma patients. And with that, I stop. Thank you.
Thank you, Hari. I think questions for him, or they may be redirected to the experts.
Yes.
It's a really nice talk. Do you have trials ongoing with any of the bispecifics in India right now?
We have one with teclistamab, which is there, which is now accruing in patients who have failed daratumumab and IMiDs. Yes, it is. Is Santosh here? Yes, yeah. I mean, my colleague is having this study. I'm sorry, I didn't understand your question. Yes, could you use your mic, please? Yeah.
Antibody with the lethal proteins, drug against the lethal proteins, sir, and what is the consequences of that?
I'm not sure. His question was, can we conjugate antibodies with lethal proteins?
Yeah, it's similar to toxin. There are proteins which are bacterial, like Pseudomonas, and I think diphtheria toxin is one of that. And some of those they are feasible, but that's very similar to belantamab. And similar specificity.
Would like to get comments from the international experts. All these trials have used patients who have completed about 15 lines of therapy, and the cytokine release syndrome of the tune of 70% and that, and then still they got response, very high response after that. What would be the performance status and other and the outcome?
So the question is are the problems associated with CRS prolonged and sustained, or is it just transient? Yeah.
So with the bispecifics, it's mostly transient, right? It's in the first 2 or 3 doses, and after that, not.
In the first 2 or 3 doses.
And even though there are many lines of treatment, because they're all on studies, they have a good performance status to an extent, and they tolerate it quite well. In real practice, then we end up putting patients who are a little less robust, and they still are, real world evidence is still quite decent. My question to you was, why in DARA exposed patient? Because by definition, as the drug is, DARA is not available, and access to DARA is not as good, why not have the teclistamab study in patients with 2 drug exposed, or at least 2 lines of treatment or something, and not require DARA exposure? Because there would be unique patient population, different from the rest of the world, that you can publish very well as well.
But they always follow what has been in the United States when they bring it to India, and that's the protocol that has been followed. For example, when we had the daratumumab study for approval, the phase 4 study in India, they brought it saying that it should be as a single agent, when we all know that that is being given up. in relapse refractory setting, but we didn't have a say in that because the protocol was
No,
such.
this teclistamab is part of international trial, so that's why they have to follow that.
Okay, then it's fine.
Yeah, so it is not.
If it's India specific.
No, it's
I
not
think
India
it's
specific.
not
It is part of the.
country-specific.
It is a part of the multi-centric global study. Yeah.
So is question for the teclistamab studies that you're doing, you're hospitalizing patients for the first week, I'm assuming.
I'm sorry,
And-
I don't have that study with me, but my colleague, but she's not here today. I think Santosh, yes, yeah, Santosh. You can use the mic on that, yeah.
We are yet to start accruing for the study, sir. But the study inclusion criteria says you have to admit for about 3-4 days after the infusion is done.
After every infusion.
Every infusion, I'll have to look at least the first few infusions you need to admit.
And how easily are drugs like tocilizumab available? and accessible?
They are freely available.
Freely.
Yes, they're freely available.
Courtesy COVID, you know.
Yeah. Courtesy COVID.
Because of COVID.
Yeah, they ramped up the thing like anything. Yes.
So thank you, Hari, and thanks to all the speakers. We end this session. Hand it over to the organizers.
We now continue with the next session of CME Talks for the day. Our chairpersons for this session are Dr. Dinesh Burani and Dr. Atul Sharma. Dr. Dinesh Burani is Director, Department of Hematology and BMT at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Dr. Atul Sharma is Professor of Medical Oncology at AIIMS, New Delhi. I cordially invite our chairpersons to the dais to introduce the speakers.
So let me begin. So till he joins, so I'm privileged to announce that the next talk will be Dr. Akhil Kumar. He's going to speak on the evolution of CAR T-cell therapy for myeloma.
Good morning, everybody. It's a pleasure and privilege to be here. So thanks to all the organizing team, and I wish to also thank Dr. Nupur a lot. I think her presentation last evening was so comprehensive and complete that it's very, very difficult to really add anything to that. So after hearing her presentation, I had to cut down a lot from what I was trying to present. So all the multiple myeloma gurus and the stalwarts are here. So what I'm going to present, some of the data are actually, you develop those data. So it's very difficult for me to really find any caveats there. I mean, you guys know it much better than what I could present. At the end of my presentation, I'm going to present the data from the CAR-T in multiple myeloma, which we are developing in India. We already have some clinical data. We don't have it from Indian patients, but we have it from our collaborator, from whom we have in-licensed the technology. So that's just 2 slides. So with that, I will go to the next slide here. And this is just, Dr. Hari just presented this slide. Means we know this very well. BCMA as a proven target in myeloma. I'm a drug developer, and these are the kind of targets we want for drug developments. Now, when we look at BCM as a target, we've already seen ADCs developed, we've already seen biospecifics, we have seen CAR-Ts. The ADCs lead to a response rate in the range of 30-35%, the biospecifics in the range of 60-70%, and CAR-Ts, luckily they have shown 80 to 100% now. Now we've already seen what has happened to Blenrep. Blenrep showed a response rate of 30% in an uncontrolled setting. About 2 months ago or a month and a half ago, we came to know that one of the phase 3 trials in which they compared themselves for superiority against Pomdex, it failed. for PFS. Now, when I look at the hazard ratio, it was close to 1. Numerically, to me, the median PFS, to my naive eyes, the median one looked better. But of course, the hazard ratio was close to 1, the p-value was not significant, the drug was withdrawn from the market. What I hear is that there are other phase 3 trials also ongoing for Blenrep. So this is not the end of the world for Blenrep, and things may come back if results of those phase 3 trials are positive, and we would know that in next 6 months, and we would really know the fate of that ADC. Bispecific antibodies, Dr. Hari just presented a huge set of data, so we know where they are, and the most recent one just got approved 6 months ago. A lot of phase 2 data from multiple drugs. So this is essentially a great target. We know how it's important in the differentiation of B cells. Dr. Hari talked about its ligands APRIL and ligand BLAF. So clearly a very, very important target. And as a drug developer, I can tell you I'm in this field for 20 years, have been part of 2 successful new drug applications to FDA. This is the kind of target we really want. And these are the 2 drugs which are approved by the FDA. Authors of the pivotal trials are in this audience. We know from the Karma trial and the Cartitude trial, and we know the differences. One of the main differences which you see from the structure point of view is the domain. So when you look at the domain of these CAR-T, among all the 6 CAR-Ts approved in the US, 5 of them have an scFv domain. And only Carvykti from Johnson & Johnson have a non-nanobody as a domain. Now, why does it make a difference? Is this what leading to wide range of difference in responses between Abecma and Carvykti? Possibly so. If you look at the nanobody, the nanobodies are much smaller. They are like 15 to 20 kilodaltons, much easier to use, much more avid. Very, the binding of the nanobodies to, the targets is very, very strong. The history of nanobodies, they are naturally occurring antibodies in camels, llamas, and that's where they come from. And the reason I'm emphasizing this, because the CAR-T which we are developing in India also has a nanobody as the binding domain. So, and that's when you see the clinical data from our CAR-T, you'll feel that it's somewhere between the Abecma and Carvykti here. So other than that difference in binding domain, the rest of the clinical data is very, very well known. We know that it has been easier for BMS to produce the drug. The vein-to-vein time was 15 days, opposed to close to 30 days for Carvykti. The manufacturing failure rate is very, very small for both of these drugs, in the range of 1 to 0%, while some of my friends who practice in the US, they tell me it's not as easy in the commercial setting to get these drugs manufactured. So while here in the clinical trial, they published the data of 0 to 1%, in actual clinical practice, it may not be as true. Now, both these trials had multiply treated patients, median of 6 prior lines of therapy. The overall response in one was 73%, in the other was 98%. And it related to complete response and the deep responses also. When you look at the stringent complete response, when you look at their MRD negative responses, all of these were much higher in the Carvykti compared to the Abecma trial. And that also shows in the PFS, in the OS, and the duration of response. And the duration of response in the Karma trial, it was in the range of 13-14 months, while in the Cartitude trial, it was not reached. When you look at the safety, both of them, they look very, very similar. Now, one thing which I noticed was different was the time to CRS. Time to CRS somehow in the Cartitude trial was 6 or 7 days, while in all other CAR-T trials, including the Karma trial, it was in the range of 1 to 2 days. So while the duration of CRS is different, the time to CRS, duration of CRS is similar, the time to CRS is a little bit different. What I'm going to do is what I looked at Dr. Nupur's presentation from yesterday. I looked at what she may not have covered, and I tried to cover that part here. So what I'm going to do is, in the next few slides, I'm going to show what are the trials which are upcoming for both Carvykti as well as Abecma. Now this one is the Cartitude 2 trial. There's multiple cohorts, at least 5 different cohorts, and 3 of these cohorts, the results of these have been published. The first 2 have been published at ASCO of last year. The third has been published at the ASH of this just preceding ASH. And the cohort D and cohort E have not been published. Now the cohort A in this trial, it took patients who were much earlier. So they took patients who were Len refractory, have been exposed to a proteasome inhibitor, and immunomodulator, they were not necessarily exposed to anti-CD38. However, when you look at the actual data, close to 2/3 of them were exposed to anti-CD38. So this was an earlier line Carvykti. The cohort B here are early relapses. These were patients in second line who relapsed after the initial therapy within first 12 months or relapsed within 12 months of the auto transplant. Now cohort C, an interesting cohort because this is a patient who has received both proteasome inhibitors, IMiDs, anti-CD38 as well as BCMA targeting therapies. So they should have received at least an ADC or a biospecific antibody towards BCMA. Now cohort D and cohort E, they are for newly diagnosed multiple myeloma patients. Both of them of course would have received some cycles of therapy, of course very small number of patients. So this is the design of the CARTITUDE-2 and the design was presented at EHA of 2021. These are the results of the cohort A. To remind everybody, these are earlier line patients, these are LEN refractory, should have received LEN, should have received a proteasome inhibitor, should have received IMiD, may or may not have received CD38. However, as I said, close to 2/3 of the patients here did receive CD38 and median of 2 prior lines of therapy. When you look at the responses here, the responses, of course, the responses of Carvykti are very hard to beat. Means when you look at responses of Carvykti in later line setting, you're talking about a response rate of 98%. And this trial in earlier line is again showing a similar response rates. 19 of 20 of these patients responded with an overall response of 95%. The VGPR or more was the same. Close to 90% patients had a CR. And among the eligible patients, more than 90% of them have MRD negative rate, which is the same as in late line setting. Just because this is very, very hard to beat data which CARTITUDE showed. So CARTITUDE-2 cohort A is showing a very, very similar kind of data. And the authors, when they presented at ASCO, they concluded that an earlier line use of cilta-cel is leading to early and deep responses in patients who had 1 to 3 prior lines of therapy and were LEN refractory. Coming to the cohort B, and these are early relapses. These are essentially second line patients who had relapsed within 12 months of receiving their induction or having received ASCT. And again, you would see a very high response rate, 100% in this trial. 19 out of 19 patients responded. Among MRD evaluable patients, 93% had MRD negative disease. And again, this trial showed that even in the second line, very, very early line, you have very high response rates and efficacy from Carvykti. Now this is an interesting trial, this interesting cohort C. This was presented at ASH a month ago. And this was a patient population which people are really trying to understand. These were patients who were exposed to BCMA therapy, either an ADC or a biospecific antibody. A total of 20 patients were presented. 13 of them were exposed to ADC and 7 of them were exposed to biospecific antibodies. When you look at the median of prior lines of therapy, there were 8 here as compared to the CARTITUDE trial where you see a median of 6 lines of prior therapy. Close to 80% of patients, they were refractory to BCMA therapy, and the overall response here was a little bit lower. Now we are seeing the response rate in the range of 60%, and the response rates were a little bit higher when you look at both the stringent response rate or an MRD negative response rate in patients who were exposed to ADC versus those exposed to bispecific antibodies, and that also shows in the duration of response. So the authors here concluded that heavily pretreated multiple myeloma patients who were previously exposed to a non-cellular anti-BCMA therapy, that favorable responses, however, both the depth as well as the duration of response appears much lower than which is seen in patients who are anti-BCMA naive. So this was one important new piece of data which emerged after ASH. We also heard this in August, and this is KarMMa-3 trial. This is the first phase 3 results, a randomized clinical trial. These are the first randomized clinical trials of a BCMA CAR-T in multiple myeloma. The company announced positive results after an interim analysis. If you look at the design of the trial, the CAR-T was on one side, and there was a choice of investigators regimen, 5 different regimens, 2 of them being DARA, 1 of them being I think elotuzumab, and 2 others, I think 1 of them was carfilzomib and 1 more. But the choice was given to the physician to choose one among those 5 forms. These were earlier patients, 1 to 3 prior lines of therapy, and company announced that the PFS has improved. The company also presented this data as an late-breaking abstract to ASH. However, it was not accepted. Now the company is presenting it at the EHA EBMT meeting next month in Netherlands. That's when we will actually know this data. The company expects to submit an supplemental NDA to the FDA this quarter, and they expect that they would have a new label on the basis of this phase 3 trial later this year. These are the key ongoing studies of BCMA-directed CAR T-cell therapy. We already talked about KarMMa-3. KarMMa-2, that's again a phase 2 study, 3 different cohorts. They're trying to compare CAR-T versus CAR-T plus Len maintenance. So the question they're answering there, if Len maintenance has a role after CAR-T, that's in KarMMa-2. KarMMa-4 is newly diagnosed patients, high risk, defined either as del17p or 1q amplification gain, at least 4 copies need to be there, and it's just a small phase 1, phase 2 studies. But what are interesting are these huge trials being done by Johnson & Johnson. Look at the sample size here. These phase 3 trials, they range in their sample size from more than 400 to more than 700. Now the first trial, the CARTITUDE-4, is very similar to the KarMMa-3 trial. So KarMMa-3 trial and CARTITUDE-4 trial are very similarly designed, except that the control arm here is a choice of 2 different regimens rather than 5 different regimens which are given in KarMMa-3. We also have CARTITUDE-5 and CARTITUDE-6, which are in newly diagnosed patients. The CARTITUDE-5 is in either transplant ineligible patients, or for some reason if the patient is not going to take transplant. Now CARTITUDE-6 is in patients who are transplant eligible. So it's really trying to answer the questions if doing upfront CAR-T is better than triple regimen followed by maintenance in transplant ineligible patients, or quadruplet followed by transplant in patients who are transplant eligible. Now I'm going to present the data which for the drug which we have licensed. This is DRL-1801. It is an anti-BCMA. It's a nanobody, just like Carvykti. The difference is Carvykti has 2 different nanobodies. It's when you look at the domain, there are 2 different domains. As we said, nanobodies are a better way of engaging their targets compared to human antibodies. It is because they have a region called CDR3. It's complementary determining region 3. And what this does is it is much longer. So if you look at the CDR, the 3 CDRs, CDR1, CDR2, and CDR3. And CDR3 is very long. It can go deep into different epitopes on the antigen, and that's why people believe that nanobodies are a better way of engaging the antigens. When you look at our response rates, and this is a phase 1 trial, a total of 34 patients, the response rates range in the range of 80 to 85%. At the highest dose, 5 out of 5 patients responded. When you look at the stringent complete response, it was in the range of 50%. Appears better than what KarMMa has shown, but appears inferior to what Carvykti has shown. The trial did not include MRD, so we do not know the MRD negative rates in this trial. When you look at the persistence of CAR-T, which is given on the left lower side, you see that our CAR-T is persisting for a pretty long time. You are seeing CAR-T persisting for year and a half, 2 years. And that may be because, we have a lot of naive cells, and, there are CAR-T trials previously. In fact, one of the second generation BB2121, the reason they were developing that because there were more naive cell population in that particular CAR-T. That development is now stopped because the clinical data, at least in the earlier trials, did not show that much betterment over the original Abecma. However, when we look at our own trial, we see that we have a substantial naive population, and our drug really lacks common exhaustion markers. We have now applied with a protocol to the Indian regulatory, and that protocol is under evaluation right now with DCGI. We expect that in next 3 to 6 months we should be approved, and then we should start clinical trials. Some of you in the audience, you are part of that trial, and we really hope to complete that study quickly. One of the questions was admission. While we have not seen substantial CRS and no neurotoxicity in the phase 1, we would admit the patient into either a bone marrow unit or a ICU setting at least for 2 weeks, at least for the first 10-15 patients, before we decide to lessen the number of days of intensive care. So that's my last slide, and I really thank you all for giving me this opportunity to present to this esteemed crowd. Thank you.
Thank you, Dr. Akhil. So questions, I'm sure there will be.
Phase 1 study. Where was the study done?
It was done in China.
Done in China.
And it has been published.
There was no data on prior exposure to drugs. So
we do. So we have in the publication, which I'm citing here, we do have, the publication does talk about prior treatments. They were primarily 3rd or 4th line setting. They were not as heavily pre-treated as the Carvykti or the Abecma trial. And in fact, when we are trying to do the trial in India, we're also looking at 3rd or 4th line setting. We're not looking into 6th or 7th line setting. And the reason for that is when we talk to our key opinion leaders within the country, they felt that we would just broaden our patient population much more if we design our trial for an earlier line.
And what was your use of tocilizumab in the trial?
The CRS rate overall was in the range of 85%. The tocilizumab was in the range of 20%. Now, part of that may be reflective of a lesser threshold to use tocilizumab, and not really, because when I look at the toci use in the Carvykti trial or Abecma trial is much more with a similar CRS rate. So I'm not seeing this as a lower CRS rate, means it's like a 3% grade 3, grade 4 here. In the Carvykti trial and Abecma trial, it's in the 4-5% range. So I'm assuming that these are very, very similar safety data. Surprisingly, we did not see any neurotoxicity there, and we really, to our partner, we really asked this question multiple times, really trying to understand what neuropathy or what's seen, not even a headache. So I think our own data in India, we would really know if that's real or not. But one thing which we can say that it's not high.
So very nice talk and very good data, very interesting. The dose looks like your target dose now is going to be 10 million per kg.
So it all depends on what DCGI asks us to do. So the way we have proposed right now, we have proposed a range. We have looked at all the different FDA labels of all different CAR-Ts and looked at how people have done and how people, the final label is. So we have proposed a range of 2.5 to 10. Now we have done 8 different rounds of manufacturing. In general, we reach about 7 to 8. The 10 million cells per kg, we are not even able to reach in our manufacturing. So it may be difficult for us from logistic purpose to reach that. So the way we have worded our trial right now is we will give a range of 2.5 to 10 depending on manufacturing logistics. But we still have to see how regulators respond to that.
And about the persistence, which is very interesting data, is there any relationship between persistence and the dose patients got?
No, we did not find that. We did find the peak relation, the peak, like what the peak you see here with the dose, but we did not find persistence related to the dose.
One other quick question, because it's really good data. Why do you think you're seeing more of a naive phenotype in your CAR T cells?
So this is one question I wish my immunologist was here, but this is the way I believe we are producing. I think we are using more of IL-15 as compared to IL-2, so they believe that it's the way we are manufacturing that we are seeing more naive cells here.
Thank you, Dr. Akhil.
Thank you.
We'll move to the next. Another topic is optimizing management of myeloma bone disease by Dr. Nupur Razin. Dr. Nupur, optimizing management of bone disease.
Thank you. I was wondering why I was supposed to come up here, but I think
you forgot about this or what?
no, we can get this done quickly. So, we're going to talk about obviously optimizing management of myeloma bone disease, and in the next few minutes, and I'll try and finish this up quickly. So, obviously, this is well known to the audience here. Bone disease is a big part of myeloma, and in fact bone disease is present in every patient with myeloma. This is really close to my heart because a lot of this work we do in the lab as well, where we look at the balance of bone cells, osteoclasts and osteoblasts. And in myeloma, the part of the reason why you have the classic osteolytic disease is because of the imbalance, where you have excess of osteoclastogenesis and very little, if any, osteoblastogenesis. So obviously over the years we've all studied the interaction of these different cell types within the bone microenvironment. We've studied the protein interactions, and with that we've been able to come up with understanding of overproduction of some of these proteins, and which results in this uncoupling of bone remodeling, which results in bone disease. So progression of bone disease can happen, and this, I think, from a practical standpoint, this is something we can talk about when we talk about the treatments of myeloma. The risk of bone disease over time does not go down in a patient of myeloma. In fact, what we are starting to see now, because of the way we are diagnosing myeloma, we are seeing less bone disease at the outset, and very relapse refractory myeloma, we tend to see more bone disease, and therefore treatment of this is critically important. We talked yesterday about imaging of bone disease, so I'm not going to belabor that at all, but in essence we've moved away from x-rays and we're doing low-dose myeloma CTs, and in specific situations we'll be doing PET CT scans and MRIs. We have IMWG recommendations to report imaging now in the context of both clinical trials as well as whenever you collect data, and this is largely so that we can uniformly compare across different trials as well. So in terms of treatment for bone disease, I think one of the most important things that one can do is, again, treat the underlying myeloma, because treating the underlying myeloma is going to get your bone disease better. And what we are beginning to see is, if your myeloma is well controlled, you're going to have very little in terms of skeletal related events, and that's why it's almost impossible or very hard to do bone directed treatment clinical trials right now, because the incidence of SREs has gone down a lot, and for us to do a bone targeted sort of a clinical trial with SREs as an endpoint requires thousands of patients. What else does one need to do? We are bone targeted treatments, and we're going to talk about that a little bit. And then there are interventions such as surgical procedures, vertebroplasty, kyphoplasty, which can be done. Radiation is used, but I would argue and say use as little radiation as possible for bone disease. We tend to use it a lot, but stay away from it, because the one thing which radiation does do, especially if you're radiating the pelvis or the vertebral bodies, you're going to compromise stem cell function, and neutropenia, thrombocytopenia can be a problem. We do now change how we use radiation, so radiation sometimes for pain control is used, but you can get away with 1 and 2 fractions of radiation, so you don't necessarily have to do the 25 gray of radiation which we are used to doing in the old days for myeloma. So this is obviously very old data, and we know that zoledronic acid was compared to pomegranate, and when you compare the two, so this was an equivalence trial which showed that both pomegranate and zoledronic acid had, at that time, this was now nearly 15 or 20 years back, the rate of incidence of SREs dropped to about 50% or so, and there was no difference between zoledronic acid and pomegranate, so you can use either for the treatment of myeloma bone disease. What has changed things was this MRC9 trial, and again in the MRC9 trial, what they did was in about 2,000 patients, they treated these patients. They had the anti-myeloma treatment was based on the MRC. They are transplant eligible, non-transplant eligible. But the beauty of this trial was the anti-myeloma therapy was a uniform treatment, and then they were given either zoledronic acid or in this case clodronate. Now this trial could only have been done in the UK or Europe because clodronate was approved out there. We could not have done this study in the United States. What was seen out here was zoledronic acid was superior to clodronate in terms of reducing SREs, and I think the other really important teaching point for me from this MRC9 trial was that regardless of patients whether they had bone disease at baseline or not, you saw a reduction in skeletal-related events with zoledronic acids. So when you treat symptomatic multiple myeloma, you should be using a bone-targeted agent, whether they have osteolytic disease or not, because it's going to prevent further SREs going forward. They did also show that if they had no osteolytic disease on X-rays, the addition of zoledronic acid decreased the incidence of these osteolytic disease. And then for the first time, showing a supportive care strategy actually impacting the outcomes in patients with myeloma, so that both progression-free survival as well as overall survival was improved in the context of zoledronic acid, for the first time showing that some kind of a microenvironmental intervention actually impacts this. And to me this was really important because, you know, when you correct for the anti-myeloma therapy, then you can look at some of these other pieces here, and that's why this MRC9 trial has been really important. Obviously with bone targeted agents we do have issues. Osteonecrosis of the jaw is a problem, and as we've been using more and more of these bone targeted agents, we are also seeing stress fractures, and these stress fractures are fractures. You could either get the fracture of the femur. Commonly we are seeing fractures of the metatarsal bones. These are where there is no actual lytic bone disease, and this happens with very little trauma. So even if you trip a little bit, patients can fracture. And one of the thought processes here is that when you're using these bone targeted agents for very long, you might actually change the bone dynamics, wherein you are increasing and causing more bone rigidity and decreasing the tensile strength of bones, predisposing them to fracture. We've studied ONJ a little bit by looking at gene expression, looking at protein analysis, and what we showed out there was that bone formation cells were really suppressed in the context of patients developing osteonecrosis of the jaw. So using these very active bone targeted agents can change the dynamics of bone remodeling, which then predisposes patients to either ONJ or some of these stress fractures. To try and understand this, and I think Pankaj, you asked us this question on using bone biomarkers and help try and see whether we can be a little more use some of these assays to better tailor therapy for myeloma. So we did a biomarker analysis here, and we looked at patients with myeloma who were in remission. We gave them 1 dose of zoledronic acid, and then we followed these patients with all the bone biomarkers. And what you can see is these bone biomarkers stayed suppressed for a very long time, for about 6 months, and these were patients who were not getting any bone targeted agent. And that's why, because these bone targeted agents are so potent and decrease these markers so much, they're not really useful in helping us tailor therapy. What we did see, then you see this one outlier here, where the anti-peptide levels really went up, and this was in concert with this patient developing a skeletal-related event. So if you can capture it, it can predict for an SRE. The question is the timing of when you do these bone biomarkers, and therefore not necessarily the best way of doing this. We, however, did do another prospective trial as well. We did what was called the ZMark study, and what we decided to do is use less frequent dosing of zoledronic acid, and the idea there was to get away from using the monthly dosing of zoledronic acid or iridia so that we don't end up with ONJ or stress fractures. We treated about 120 patients with this. The problem with the study is it's a single arm study. We used baseline anti-peptide levels. If they had anti-peptide levels above 50, we gave them monthly zoledronic acid. If it was less than 50, we went to every 3 months. What we found was, there were a few patients who were getting it monthly, but within a couple of doses of zoledronic acid, everybody's anti-peptide level was down, and everybody ended up getting the 3 monthly, so almost became kind of a single arm phase 2 trial. What we were able to show with this trial was the incidence of ONJ was about 3%. The incidence of SRE in the context of these newer drugs, now the old data that I showed you was 50%. With this study, it was about 4 to 5%. So the rate of SREs has gone down, and therefore doing prospective trials really requires a lot more patients now to show the same data that we showed more than 15 or 20 years back. So what do we know about bisphosphonates? We know that they inhibit bone resorption. We know that permidronate is better than placebo. I've shown you data that permidronate and zoledronic acid is equivalent, and we do know that zoledronic acid, based on the MRC trial, has a survival advantage, and we also know that we can use zoledronic acid less frequently. I'm showing you the ZMark trial. There was another trial done by the cooperative groups as well, which has used 3 monthly zoledronic acid, which is effective in reducing SREs in patients with myeloma. What about other drugs? So rank ligand obviously is increased in patients with myeloma, and we know that for a fact by looking at bone marrows from patients. We also know serum levels of rank ligand are specifically increased. So way back when a trial was done by Amgen, this was the famous study 244, and what was seen in this phase 3 trial, so what they ended up doing, I think, which was the problem with this trial design, was they included myeloma with all other solid tumors. So they did a big breast study, they did a big prostate study, and then all other bone disease, including myeloma. So kidney cancer, lung cancer, myeloma was all grouped together, and denosumab was compared to zoledronic acid. In myeloma, they did not control for anything in this study, and what was seen out here was a survival disadvantage to denosumab when compared to zoledronic acid. Now to us that was a bit of a surprise. We didn't quite understand why. So we took the zoledronic acid data from the MRC trial, extrapolated it on this trial to see why were we seeing this discrepancy, and the zoledronic acid arm in this Amgen trial was completely off, suggesting that we needed to look at this data set as to why this was going on. When we did a retrospective review of this study, we did find specific baseline problems with the denosumab arm, where less patients were transplanted, performance status was different, kidney function was different, which could have explained the survival disadvantage. And that's why, given that we know the biology of rank ligand so much better in the context of myeloma, we went ahead and did this phase 3 trial. This was probably one of the biggest clinical trials that we've done here, 1,700 patients, and we needed the 1,700 patients, even though it was we did an equivalent study. So we were comparing a very potent bone targeted agent, zoledronic acid, to denosumab, and the end point here was skeletal related events, because we were using that as a registration trial. What we found out here was it was truly non-inferior to zoledronic acid, so denosumab works just as well. But the other important part that we wanted to confirm was his overall survival disadvantage. And what we found here was no overall survival disadvantage. And what we done in the study prospectively was risk stratified patients based on ISS staging and based on transplant versus no transplant, in which region of the world they come from, because of the novel treatments afforded to these patients. And what we found here was once you risk stratify, you do not see a survival disadvantage. But the other thing we also looked at was wanting to look at a PFS as a secondary endpoint in this patient population, and we actually saw a benefit of PFS in the denosumab arm by about 10.5 months.
So we compared our data with West, and obviously there are differences. For amyloidosis itself, if you see in West, most of the amyloids tend to be AL associated, whereas our amyloids 70% tend to be SAA associated. So out of generally we have 20 amyloidoses in 1 year, out of which only 6 are AL associated, rest are SAA, and out of which only 1 or 2 per year tend to be associated with myeloma. So we published some of our data. If time permits, do we have time? 3 minutes. So this is a photograph of amyloidosis where congophilic material and acellular congophilic material, which is orange looking in the second panel with bipolar fringes. That is how we make amyloidosis. As I said, 70% of our cases tend to be SAA associated, only 1/3 are AL associated. This again looks like amyloid, but this is PS positive and it is congruent negative, and it tends to be along the tubular basement membrane is also thickened. So when we did immunofluorescence, it has only IgG.
neutropenia. In myeloma patients, maybe we can classify them as host-related, disease-related factors and treatment-related factors. So the host-related most important include age and comorbidities. There are 5 independent risk factors which predict reduced overall survival in myeloma. That is the host-related factors: age more than or equal to 5 years, renal dysfunction, pulmonary dysfunction, poor performance status, and frailty. And a myeloma comorbidity index combine these elements to identify 3 risk groups: fit, median overall survival of 10.1, intermediate fit, median overall survival of 4.4 years, and a frail group with a median overall survival of 2.1 years. So naturally, intermediate and the intermediate fit and the frail patients have high risk of infections. What about the disease-related risk factors? The most important disease-related risk factors for the development of infections are the burden of the disease. Higher the tumor burden, higher the risk. So ISS2 and ISS3 patients are at increased risk for infections. Similarly, raised LDH, which is an indirect indicator of the burden of the disease, also indicate that the patients are at a higher risk for development of infections. Status of the disease: the period of the highest infectious risk is during the first 3 months after diagnosis. Also, patients of relapsed and refractory myeloma are also at an increased risk of infections. Coming to the treatment-related risk factors, the risk varies depending upon the treatment phase, whether it is induction or whether the patient is in remission or the patient is as a relapsed or a refractory patient. The extent of the previous therapy, single line of treatment versus multiple lines of treatment, the intensity of the treatment, doublet versus triplet, the standard dose chemotherapy or high dose chemotherapy, and the type of agents as well as the dose. So if you see the type of therapy and the susceptibility, we all know that glucocorticoids cause lymphopenia as well as hyperglycemia. So such patients are at an increased risk for fungal infections, viral infections. Not only that, the cumulative dose of dexamethasone also plays a role. So that is an independent risk factor that we have seen in the ECOG study. When the dose of dexamethasone which is used is more than or equal to 40 milligram per day for 4 consecutive days every week, there was an increased risk of opportunistic infections including pneumocystis. Cytotoxic chemo, they cause neutropenia, T cell dysfunction as well as mucosal damage, and that can predispose to bacterial, viral as well as fungal infections. Autologous hematopoietic stem cell transplantation, mainly mucositis, neutropenia and mucositis resulting in bacterial infections, but rarely there can be T cell immunodeficiency once the engraftment occurs, during which phase the patient is at an increased risk of viral infections and pneumocystis. Proteasome inhibitors, T cell depletion, we all know that it causes reactivation of varicella zoster as well as herpes simplex. Immunomodulatory drugs like lenalidomide and pomalidomide, the main increased risk of infection is from neutropenia. Monoclonal antibodies, again lymphopenia, and such patients are at a higher risk for reactivation of varicella zoster as well as other opportunistic infections. Panabinostat, lymphopenia and neutropenia, again you can have bacterial, fungal and other viral and opportunistic infections. Selinexor, neutropenia, again the organisms are Candida, pneumocystis and Pseudomonas. We have heard about the novel immune approaches like CAR BiTEs and the antibody drug conjugates. Again there is the pathogenesis of hypogammaglobulinemia and neutropenia, again predisposing to bacterial, viral and fungal infections. Anti-resorptive therapy, again we saw such patients are at an increased risk for osteonecrosis of the jaw, and anaerobes are the ones, the underlying causative pathogens. So are there predictors of early and severe infection? Yes. High tumor burden, again ISS 2 and 3, raised LDH, as I told, indicating an indirect evidence of the burden of the disease, poor performance status, renal dysfunction as well as the males. So if you see all this, most of these predictors of early and severe infection are either the host related or the disease related. Spectrum of infections. Most infections in patients with multiple myeloma are caused by viruses and bacteria. The bacterial infections manifest most commonly as pneumonia and bacteremia. So if you see active myeloma in the beginning, such patients are at risk for infections with the encapsulated bacteria, mainly Streptococcus pneumoniae and Haemophilus influenza. As the disease advances, as the immunoparesis becomes more severe, when the burden of the disease is high, when there is neutropenia setting in, or when there are associated comorbidities like renal failure or immobilization as a result of spinal cord compression, then the patient becomes prone for more severe infections, for example with Staphylococcus aureus, gram-negative bacteria and gram-negative bacteria. Relapsed refractory myeloma is a setting where you will see infection with uncommon organisms like pneumocystis, aspergillus, and even CMV, hepatitis B, HCV, parvovirus B19, and even tuberculosis. So what are the strategies to prevent and manage infections? Assess the risk of infections in patients by doing a history, take about the history about the comorbidities, history of vaccinations the patient would have received, any previous history of infections. Performance status, as I told, poor performance status indicates that the patient is at a higher risk for infections. Assessment of the functional status, you can stratify the patients into fit, intermediate fit, or frail based on the factors which I had alluded to earlier, and estimate the burden of the disease, and then you will have to chalk out an individualized treatment plan. You may even have to optimize the dose intensity of the treatment when you initiate the treatment. So preventive strategies, I think most of the preventive strategies, the main preventive strategies would be vaccination and risk adapted antimicrobial prophylaxis, which has already been covered. In addition, patient and caregiver education also can play a main role in prevention. I think in such situations, management of infections, I think we do day to day. We are all experts in management of febrile neutropenia, so that area I will not be covering. So mainly the preventive strategies, the others being immunoglobulin replacement and the growth factor support. So antimicrobial prophylaxis, antibacterial prophylaxis with levofloxacin, you may consider it during periods of increased infectious risk, especially during the first 3 months of therapy. Acyclovir prophylaxis, of course, we all routinely use this in patients receiving proteasome inhibitors or targeted monoclonal antibodies, especially the daratumumab. And patients who are seropositive for herpes simplex virus and varicella zoster virus, if tested, may also receive acyclovir prophylaxis. Trimethoprim sulfamethoxazole prophylaxis, of course, for patients at high risk for pneumocystis jirovecii pneumonia. Those are the patients who are having relapsed and refractory disease. And of course, sometimes we combine antibacterial, antiviral, anti-pneumocystic, as well as fungal in high intensity protocols. For example, when we give a DT pace or similar high intense regimes. So there is a GEMPATHEMA score which has been developed by the Spanish myeloma group to predict the early severe infection in myeloma. The 4 variables were included in this. These 4 variables were found to be significant on multivariate analysis: low albumin, an ECOG performance status of more than 1, male sex, and a non-IgA type of multiple myeloma. So based on this, they found that in the low risk, who was having 0 to 2 risk factors, had a low incidence of early severe infections, whereas the intermediate one with 3 points, or the high risk one with all the 4 points, were at a higher risk of early severe infection. So in this way, you may even risk stratify patients into low risk, intermediate risk, and high risk. So for low risk patients, you don't require any prophylaxis, be it bacterial, fungal, or viral prophylaxis, whereas intermediate risk and high risk patients may receive prophylaxis. I think what prophylaxis can be given, we have already discussed in the previous slides. So preventive vaccination, Madam has extensively covered. Vaccines are safe, cost effective, and avoid serious infections, but clinical trial data on the efficacy is limited. So the major benefit of vaccination, if at all, is that it reduces the rates of infections and hospitalization. So although recommended, we all know that in our real world practice also, the rate of vaccination remains low. So only inactivated vaccines to be given. The vaccines which may be considered are influenza vaccine, pneumococcal vaccine, H influenza in those who are splenic, as well as non-live zoster vaccine, and the hepatitis B vaccination, of course, is recommended as part of the universal immunization program. So vaccination timing, again, it was discussed. Protection by vaccination is best achieved when the vaccines are given in the early disease stages. So if you have the opportunity of detecting the disease when it is MGUS or smoldering myeloma, I think that would be the ideal time, or before the initiation of the treatment, or if already the treatment has been initiated, maybe when the response is reached. So during treatment, the chance of having a good immune response is less. So after autologous stem cell transplantation, patients with multiple myeloma might lose their immunity to the pathogens against which they were vaccinated. So such patients should be revaccinated 6 to 24 months after the hematopoietic stem cell transplantation. So I think these we have already seen the vaccines which can be given. The pneumococcal vaccine recommended for all patients, influenza vaccine also again for all patients, as well as the varicella zoster recombinant non-live vaccine, if possible, is advisable to be given for all the patients. So the question comes, if the patient is vaccinated, is antimicrobial prophylaxis required? Yes, because the response to vaccination may be suboptimal and the degree of protection is not predictable. So just because a patient has been vaccinated, that doesn't mean that you can get away with antibacterial prophylaxis. Immunoglobulin replacements, there is scarce data, high cost, limited availability, and the potential for complications. So it has to be reserved for specific situations where such as recurrent and life-threatening infections, despite appropriate antimicrobial prophylaxis and immunization. So you may look at the immunoglobulin concentrations, but you always remember that IgG myelomas may be there, and it may be it may show it may be elevated in such patients. So growth factor support indicated when the anticipated risk of fever and neutropenia is at least 20%, so which is applicable for all other chemotherapies and malignancies, such as autologous hematopoietic stem cell transplantation when you are giving CAR T-cell therapy, or as I told, the conventional chemotherapies with multiple cytotoxic agents. And also it may be used to prevent delays when you are treating with lenalidomide. COVID-19 vaccine recommendations also have been discussed, so I am skipping that. So coming to the summary, several factors account for the increased infectious risk in myeloma: the overall state of immunosuppression from the disease, treatment, age, as well as comorbidities. And the period of highest infectious risk is during the first 3 months after diagnosis and when treating relapsed or refractory myeloma. Antimicrobial prophylaxis and preventive vaccinations can be effective strategies to prevent serious infections. However, we have level 1 evidence for these interventions only for acyclovir prophylaxis when you are giving proteasome inhibitors or targeted monoclonal antibodies, and also for recombinant zoster vaccination after autologous HSCT. So an individualized patient-specific plan needs to be implemented to prevent and manage infections. So here is my conclusion slide. Infectious complications remain a clinically significant cause of morbidity and mortality in myeloma, and an individualized treatment plan adapted by risk is the key to reducing the burden of infectious complications. Thank you.
So thank you, Lino. We may have 1 or 2 questions regarding infection in myeloma.
So this is regarding, this is a comment on the vaccination practices in the country. In India at least, the pneumococcal vaccine and the influenza vaccination is not part of the schedule, although some states have incorporated PCV13 as a part of the schedule. So we are like far away from any effective adult immunization program. At least in PGI, what we are doing is when we were actually diagnosing patients with myeloma, before therapy was initiated, we were at least discussing the aspect of vaccination with pneumococcal conjugate vaccine and influenza upfront in all the patients. It was an informed choice. We went on to do a seroconversion study as well, where we actually showed that the seroconversion rate is close to 60%. So I think we must make it a point to discuss the options of getting vaccination, especially against influenza and pneumococcal ab initio in all cases of myeloma before upfront therapy is initiated.
Okay, noted. Well taken. You have a question? Quick.
Sir, do you routinely use antimicrobial prophylaxis in the first 3 months of myeloma, and if yes, which drug do you prefer, sir?
Yeah, not in all patients, selected patients, especially age more than or equal to 65 years, poor performance status, associated organ dysfunctions like renal dysfunction. In such patients, we usually prescribe for the first 3 months, and what we usually use is levofloxacin.
All right, thank you very much. So now, just to save time, I request Dr. Pravas Mishra to come over to moderate a panel on special situations in multiple myeloma. And also I can request all the panelists who are this thing. So Vishwanath from Bengaluru, Rajat Bahal from Bengaluru, Aniba from Bengaluru, Suvir Singh from Ludhiana, and Ashish Dixit, is he around? And Ganesha from Bangalore. So all from the local guys most.
Good afternoon, and thank you, Hari, again for inviting us over. So I am going to be doing a panel discussion on management of special situations in myeloma. So I was kind of not sure exactly to begin with what special situations, so I got the agenda much later. So I just selected 3 case scenarios, and thankfully at least one of them was part of the special situations talk that just happened right now. So we have Dr. Vishwanath, Dr. Rajat. I am not here. Yeah, he's Dr. Rajat. Dr. Ashish, I know, of course, both of us are from AIMS. Dr. Annie and Dr. Suvir Singh. Dr. Vishwanath. So we don't have 2 of the panelists here then, right? Okay, no problem. Dr. Ganesha is not here and Dr. Suvir Singh is not here. Okay, so that's also a reason why I didn't put names to the questions. So I've just put up some case scenarios and then we will go along with that. This doesn't seem to be moving forward. Oh, okay. Thank you. So the first case is a 65-year-old gentleman who presented to us with breathlessness of sudden onset. He had atrial fibrillation and a restrictive cardiomyopathy. This is the echo on the side. He also had proteinuria and some hepatomegaly on examination. So this was a gentleman who came to us with breathlessness, cardiomyopathy and atrial fibrillation. The CBC was normal. The liver function test, the GGTP was 105. The alkaline leukocyte phosphatase was normal. Total proteins were unremarkable. Ultrasound showed a 15.7 centimeter liver. The kidney sizes were normal. 24-hour urine protein was 1.5 gram nephritic range. TROP-I was 0.2. NT-proBNP was 3050 picogram per ml or nanogram per ml, whichever SI units you're using. The serum free light chain was 1000 to 22 more of kappa, and the protein electrophoresis, both IFE and serum protein electrophoresis, was again non-informative. So this was the hemogram on the left hand side. So that is normal. Urea creatinine is normal, and this is the protein creatinine ratio in the urine, which is increased. Bone marrow biopsy had 25% plasma cells. FISH for myeloma was non-informative, and there were no lytic lesions on the PET-CT. This was the biopsy of the kidney, which showed basically kappa restricted amyloid deposits in the kidney. So this was a renal amyloid that we were looking at. So I'll start with Ashish. Would you consider this patient to be transplant eligible? And there are 3 questions here, so we'll take one question and go along down the line.
Sorry, I missed the age of the patient.
He's 65.
65, all right. So 65-year-old, this patient with atrial fibrillation already requiring anticoagulation will be very borderline candidate. So I would rather prefer to go all aggressive, use that money to use daratumumab as a first line therapy and go ahead with that. I won't be very comfortable doing transplant at this borderline age group. Younger patient, yes, I would have possibly considered, The transplant mainly for a long-term objective, mainly because it will provide a longer disease control comparatively. But if I'm using daratumumab based therapy, then mostly I'll give a choice not to do it.
I'll just shut down my phone. Right. So yes, I agree with you, Ashish. He is 65-year-old. Additionally, he also had atrial fibrillation to begin with. He has some cardiomyopathy. NT-proBNP was on the higher side. I would also not take this patient up for a transplant. But in case, suppose we have two patients who have been taken up for transplant, what dose of melphalan would you consider for your patients with amyloid? For him, sorry.
So we'll first look for any, what is the ejection factor, basically the age, then we'll go for a, what is the, basically if the patient is not, basically age, sir, and then the stage, the Mayo stage, sir, of the cardiac stage, sir, basically.
Yes.
Look for that. If it is stage 1 and 2, then only we can give a melphalan at dose of 200, sir.
Yeah.
Otherwise, we have to reduce the dose of melphalan to 140, sir.
Yes, so I mean we do stage it and we look at risk factors. For example, this person would be in stage 3A and he's 65-year-old. If in case we do go on for a transplant, we use 140 dosing for this person. Are there any precautions that you would like to have during stem cell mobilization and transplant?
Yeah, so between myeloma and amyloidosis, myeloma is more like a bone marrow disease and amyloid is more of an organ dysfunction disease. So even during stem cell mobilization, there are quite a few factors like with GCSF and Prolixafor, it's okay, but use of cyclophosphamide should be used with caution, chance of hypotension, organ dysfunction, and during transplant again, volume overload and engraftment syndrome. Multiple factors are there which could complicate the scenario.
The way I look at it for transplant is, instead of thinking of all the possible indications that are there, it's good to just go from the exclusion. So if you have got somebody who has atrial arrhythmias, ventricular or atrial arrhythmias, somebody who is symptomatically, who has got pleural effusion, uncompensated heart failure, bleeding. So these are the patients that one would not take up for a transplant. We discussed this already. We do try to stage these patients to see whether we can take them up. So if you don't take this up for a transplant, induction therapy, what would be your treatment of choice and how many cycles?
The induction therapy, my choice would be DARA VCD, at least 2 to 4 cycles, and then reassess.
Any other comments there?
Sir, actually, DARA for 2 cycles, with weekly doses, then we'll reassess, sir. And if it is not in remission, then we can continue with DARA at fortnightly doses, sir, for next 4 cycles, sir. If you're not taking the patient for transplant, sir.
So I have never used DARA for for practical reasons, for cost reasons. I do know that for induction therapy in amyloid, they do say that you should take up DARA now. But I don't have any patient who is on daratumumab with amyloid. Almost all of them are being treated just the way that I would treat them for myeloma, and take them up for bortezomib, cyclophosphamide and dexamethasone, 4 to 6 cycles, and then probably with some kind of maintenance. So this gentleman, we started him on VCD, bortezomib, cyclophosphamide and dexamethasone, and after 5 cycles of therapy, his sinus rhythm was, he was in sinus rhythm, he didn't have any arrhythmias, his ejection fraction was 60%. At that point of time, there was some bump up in the kappa lambda ratio, he was worried. We went ahead and did a bone marrow, which was just showing about 4% of plasma cells. In case you do start out with a transplant, and this is for you, would the response to induction affect your decision to transplant in any manner? Like, are there any circumstances where a patient whom you initially thought to be transplant eligible, you could defer the same?
So number one would be progressive disease, either organ progression or even the hematological progression. Second thing is, even if this CR, based on the Andromeda study, which Dr. Shaji Kumar very nicely explained yesterday, so patients who have a complete response, and that may obviate the need for transplant, and the patients with who are on daratumumab, there may be more complications, cardiac issues when we are using DARA, so that again is an issue.
Would you give maintenance post-transplant?
For the patients who were taken up for transplant and had less than VGPR, they should be given on put on maintenance. That's what we followed, because invariably many of them had almost like a PR kind of a thing. So maintain the response, we have given maintenance.
Yeah, so there is, unlike myeloma, we don't have enough data to say that whether to give maintenance or not. I think, but as a practice, we all end up giving maintenance post-transplant. This again is a criteria for organ response and progression of amyloid. Now, this patient we started on bortezomib maintenance. So he was getting bortezomib once every 2 weeks, and this was a kappa lambda. It bumped up sometime in September. It went up to ratio went up to 9. His NT-proBNP was 786. It was 3050 to begin with. So at this time we decided to start him on pomalidomide, and after pomalidomide 2 cycles, the ratio came down to 2.5. His NT-proBNP is 2610. This is possibly due to the pomalidomide. It's just a laboratory thing which happens with IMIDs. So that was this case. If there are any comments from the audience or from others, then we can move on to the next one. Yeah.
Sir, your comments on use of doxycycline. Many people in the country, for the patients with amyloid, give doxycycline. What's your take on that?
So I am not using it. There is no data to actually say whether to go for any kind of cardioprotective agents or not. People have been using it, but I have not used it. Have you used it? And what is your experience with it?
If you have used and you have experience, you can share that first. Then my experience is gone. Just making a comment on the use of cyclines in that, because I think there is a trial running. So I think from that perspective, it will be important to see the response to that. There was a Chinese data on one of the tetracyclines. So that was not showing any major impact of addition. So you can share what you have found.
Anyway, both we and even the CMC Vellore, we have been giving it for last 4-5 years.
We
For
have been-
every patient that of amyloid, we have been given doxycycline. But the problem is it's a single arm at the end of the day. Now we really don't know. We don't have a comparator to say whether this was helping or not. So many of the patients improved because we transplanted them. We went with the conventional therapy.
So you are using doxy with. So you never know whether.
Yeah, absolutely. So both Vellore as well as we, both of us are doing single arm, but even Anup has been giving it for quite a number of patients. But we really don't know whether it is benefiting or not. So we have to design actually a controlled study to understand that.
So if there are no other comments on this, then we can move on to the next one. So this is a monoclonal gammopathy of renal significance. We have had 2 presentations on this today morning. So this is a 56-year-old male who had hypertension since several years, but this was intractable over the last few months prior to his first consultation in nephrology. His hemogram was unremarkable. Urea was 66, creatinine was 2, liver function, thyroid, ultrasound of the kidneys was fine. But what we did find on the renal biopsy was a C3 glomerulopathy. The urine microscopy showed blood, RBCs were there, protein was increased, and the protein creatinine ratio was 4.1. Immunology markers which we did on the marrow was non-informative. Protein electrophoresis did not show any M band on immunofixation, but on protein electrophoresis, but on immunofixation we found IgG lambda, and the same lambda band we found in the immunofixation of the urine. The kappa lambda ratio was unremarkable. Again, both kappa and lambda were raised. Beta 2 microglobulin was 9,776, and a bone marrow examination showed a plasma cells which were just about 6 to 7% of the total marrow. I think. Yeah. So this gentleman again, we did so I think this is the same one. So the echo and all was normal. Then we did the biopsy of the kidney that showed a granular immunoglobulin G kappa deposits in the kidney. So the question here, starting with Asis, would be when would you suspect and how do you diagnose an MGRS?
I think for MGRS we are heavily dependent on the pathologist.
Yes.
They are the one who tell us whether it is involved or not involved with the tissue. So it's an involved site where the renal disease, renal biopsy actually helps us diagnose. Most of it is dependent entirely on electron microscopy, subsequently immunohistochemistry on that. So if we have already documented, I think, IgG kappa on this patient, and electron microscopy also was, so kappa restricted infiltrate, and electron microscopy was also suggestive. So this is somewhere where it is not fitting. It's an organ involvement, but it is not fitting with anything else other than possible no MGUS of that sort also. So it doesn't fit in with the smoldering MGUS or any of the categories. So it will be MGRS here.
So it's important to get a biopsy of the kidneys here, because we quite often face this issue. So you don't necessarily get all the other CRAP criteria. You don't get all the criteria to diagnose a myeloma or even an amyloid. And the only way to diagnose it would be to do a biopsy of the kidney. You might or might not get, in this case we did get a kappa. We had another case where we didn't have it, and it was tough to actually say that you have MGRS and you need treatment for myeloma. What would you give for an MGRS? How would you treat an MGRS?
MGRS treatment depends upon the reason. We have to see the plasma, the clone basically, if it's a plasma cell or a B cell type. So if it's a plasma cell, then we'll go with a bortezomib based therapy, and if it's a B cell, then it will be rituximab, anti-CD20 based therapy.
Would you manage an IgM deposit separately?
Yeah, I think that Dr. Ani has
Yes,
mentioned.
you did.
So it's a rituximab based therapy.
Yes. So if it is an IgM deposit, then you would rather go with a lymphoplasmacytoid kind of approach. So that was about MGRS. We generally end up treating them like for any other myeloma. Would you go for a transplant in these cases as a consolidation?
For MGRS, no. I don't. Yes, most of them respond very well, and then after that they stay in that. So if there are peripheral markers, we'll go by that, or we'll go by the renal deteriorations. They are not the candidates for transplants.
Yeah, the only way we follow them up is looking at the protein loss in the urine. The last one that we have is extramedullary disease. So this was a 53-year-old who presented, this was not my case, this was from outside, and presented with backache, and paravertebral lesions were there with soft tissue involvement, bone marrow was involved. The routine markers, they were all informative for myeloma, and this patient was started on a VCD kind of a protocol. And subsequently at follow-up, they did a bone marrow examination because this patient continued to have a persistent backache, and otherwise all other markers were negative for progression of the disease. They did a bone marrow which also did not show any increase in the plasma cells. However, when they did the MRI at this point of time without any marrow involvement or any other markers, so it showed that this person continued to have a lesion at the D7 to D9 level with some degree of cord compression as well, and some right-sided pleural effusion. So this was essentially somebody who had just extramedullary disease at progression. How do you help us manage this patient?
Initially we can plan for radiotherapy to the supply radiotherapy to the bone or the region radiotherapy.
Yeah, sorry.
And we can have a bone directed therapy, sir, for this patient, basically, and followed by if the patient, since the patient doesn't have any bone marrow involvement, sir, so chemotherapy we can wait, sir. If it is a solitary plasma, solitary lesion only, then radiotherapy will be better for the patient.
So this is somebody who has progressed from a myeloma. Would you, he suggests that we should just go along and give radiotherapy. Would you have any other inputs on that?
I would probably add systemic therapy also. I would change, and there is also some data on it, though it's rare. In fact, I was asking this question to Dr. Nupur yesterday about the role of DARA in EMD, and now there's also some data that IMIDs are more active, POM, and POM has got activity in EMD.
Yeah, so this was not my patient, but previous patients I had, and EMD is rather an uncommon condition. I mean, it's quite unusual to have EMDs right at the beginning or even at progression. The overall incidence is somewhere around 13%, 7% at diagnosis, 6 to 20% at relapse, and the overall response rates and the prognosis in this group of patients is quite poor. So this is, the lower paper is from Kumar, Dr. Lalit and his group from AIMS, and they had just a 9% complete response rates and progression-free survival of just about 18 months. So the outcome in these patients is quite dismal. So in somebody like this, I would probably, I started to treat them as, I would treat them as with the systemic kind of a therapy and take them off for a transplant as quickly as possible. But even with any of these therapies that we have given, for example, even in these 2 or 3 studies that I've added here, with the standard therapy, the response rates are just about 20 to 34% with a very poor median free survival. So there is data on daratumumab. I was not there yesterday, but I'm sure that is what is coming up for EMDs as well. Ashish, any things before we wrap up?
No, I think I'll just second that part only.
So if there are any other comments from the audience or anyone who wants to add to these?
So just a comment on the doxycycline use which was discussed. Just a comment, Dr. Arun here, sir.
Yeah.
So this was just a comment on the evidence base for doxycycline use. Now we have a phase 3 trial in cardiac amyloidosis where doxycycline was used on a randomized fashion, and it has not been found to be of any PFS benefit or cardiac response benefit. So at least with respect to doxycycline, with the phase 3 data, I think the evidence is there to suggest that it really doesn't affect outcomes.
I agree. So that's all from my side. Thank you so much. Thank you to my panelists. Thank you.
Thank you, Dr. Pravas, and all the panelists. We will now break for tea and restart in 10 minutes. Good afternoon, everyone. We now resume. Up next, we have Professor Dr. Nikhil Munshi with a talk on how close we are to curing myeloma. We graciously invite Sir to take the stage and deliver his talk.
Well, so we are to the almost end of this very, very successful meeting with lots of good clinical care, science, and discussion of the disease management in light of the local access and local conditions. And so now for the final couple talks, I'm going to talk about more philosophical thing and where we are going, or more importantly, where we are. So these are my my disclosures. So when we're talking about cure, what is the definition of cure? And there are many definitions, and I will not go into detail. We can probably spend 1 hour talking about how do you call cure. But 50 plus years ago, there was an official definition, which was that after treatment, there would be group of people who would not have any disease and whose eventual death rate of all causes would be similar to the general population. And then there was a revision to this official, made it simpler that it should be something that is not associated with any disease related illnesses or problems. And again, there are many nuances to it. And a simpler definition one of the patient gave was that cure is something where you grow old and die from something else. All means the same thing, that you won't die from the disease. And we all know that a lot of our patients do not die from myeloma, they die from something else. So when we look at cure and look at the survival curves, we should look at other diseases which we know are cured. DLBCL or Hodgkin's lymphoma, and you can see this beautiful line at the top. Even for CAR T, when you see DLBCL, post CAR T cell, 40% patients don't relapse after 2 years. In myeloma, the curves used to be are like this. Patients keep on relapsing even after years, and this particular study was 10-year follow-up, and we still see patients relapsing. So where are we now? Now, one of the older studies that I had a pleasure and privilege to be involved in was this total therapy program in Arkansas with my good friend and colleague Dr. Barlogh initiated. And if you look at the studies done there from total therapy 1 and 2, and then beyond my time there are 2 and 3 actually, and there is a 4 and 5. But you could see that the survival curves are increasing, they're going up. And so with each addition of the drug, with thalidomide for total therapy 2, and then bortezomib and others with 3 and 4, the survival curves are improving. So we are definitely doing better. But the question would be, how do we cure any cancer, but in our case myeloma? So there are 3 or 4 things to look at, and one of the first principle is that the first shot we get would give us the best chance of a cure. More you allow patients to relapse, the chances of cures get less. And why is that? And it's because of many factors. And one of the factor is that as patients get more lines of treatment, their ability to get more lines or subsequent lines go down, and their improvement goes less. So if you take any study with first, second, third, fourth line, the PFS goes down, the response rate changes, and then not as many people get the treatment. And so then if you look at biologically why is the case, it's because how genomically the disease evolves. It starts with one cell, becomes 2, 4, and 6, and then it starts with one mutation, which is a green cell, gets the red and the blue and yellow, and it's a mixture of those cells. So when we start treating, we may get rid of all the red cells, but the blue and green are still there, and they can grow. And the complexity of the genomic changes as it happens over time with all various clonal variants that come up, they may have all very distinct properties, or some of them have distinct property, and that makes the treatment more difficult. So when you, in the end, if you have 10,000 clones, we can eliminate 9,900, but there might be 100 clones that we cannot. Versus when that clonal architecture or complexity is only 1,000 cell, we can get rid of 999, and there are only few left that the body's immune system and other processes could take care of it. So one of the studies that was published, and again I think this was Dr. Boli's work, which was smoldering patient progressing to myeloma. So what changes genomically when this happens? And in this particular study, it was a smaller study, it was a 12-patient study, which showed that the complexity in smoldering is not very dissimilar than myeloma. There are still 7,000 mutations. It's very complex. But when we had sample from the same patient when it became myeloma, so they were paired sample, smoldering and myeloma, half of the patients had what in this Dirichlet curves you see, and I don't know how to show, yeah, there it is. So this is where, what it shows is that in this particular group of 5 patients, their genomic architecture did not change when they went from smoldering to myeloma. Versus this second group is where there was a new mutations acquired, number of them, before they became myeloma. And what it means is that these patients, these are the ones in the red here, their time to progression to myeloma was 7 months. So it's almost, they were already myeloma. We just didn't call them because they didn't have kidney failure or something. We were waiting for something to break before we call myeloma. The other group is where they required new mutations and new genomic changes before they became. And so as we wait, the complexity, as you see here, changes and increasing. And this clonal evolution and aggressive transformations are driven by many of the processes. And this is what some of it I described in the first place. And so we need to keep this in mind as we look for curative outcome in this patient population. This is one example where a patient started with smoldering with certain cytogenetic changes. At a newly diagnosed stage had acquired many more mutations and also many more copy number changes. And then at a relapse stage, it got even more complex. And so I'm sort of saying the same point with different examples, that we don't want to be in the last setting where it becomes more difficult to cure this patient. So when we look at complexity of the genome and the cure rate or even eventual outcome in this whole genome sequencing data, you could see that patients in the blue are with less number of mutation, in the red are more mutation. And there's a clear difference in the survival outcome. What it tells you again is the same point. More complex the genome, more difficult to get rid of the disease, and more quicker the time to relapse. And then as I had mentioned earlier on the first day, there are many processes, and we and others are looking at all these various molecular processes which causes these mutations. And just to highlight the point how important it is to do the best treatment first, all these processes are active in myeloma and in many other cancers. And you can look at, and we have all sorts of assays that can measure this activity now, so that could also become clinically usable component to it in the long run. But using this in vitro assays, we have also inhibitors of this process, so we can prevent the genomic evolution, so to say. And all this together is providing and will provide ability to stop this progression. So then we can treat the disease without worrying about it. And this homologous recombination, and I'm going a little fast for a complex topic, but this homologous recombination is one of the primary means how myeloma cell acquires the genomic change. And so the green and black bar are myeloma cells, the red is normal cell. There is always a level of normal HR activity. Myeloma is significantly high. And what it does is that the blue bar in the middle are when the homologous recombination is high, and each blue bar just suggests a new mutation or new copy number change. You can see when you increase the HR, it significantly goes up. That's what happens in myeloma. And it leads to also development of drug resistance. In this particular study, what we did was we induced recombination, and then we were able to have the cells acquire dexamethasone resistance in a very short period of time. So these are the complex thing, and to even expand it to causation of cancer, when we increase the HR activity through this particular gene apex, we could induce chromosomal changes in the myeloma cells, or in normal cells in this case, which became malignant, they can develop tumor. And also we develop a fish model where by overexpressing this gene, fish develops tumors. Here it was expressed in the eye, so it had developed a type of retinoblastoma. And so point is that we want these processes to be controlled and treat the disease before all these complex changes happen, and that's a way to treat the disease best. So don't save the good treatment for later. Use it in the first shot. The second is that we need to get a deep response. So that's our second thing, need to attain the deep response. And we know the combination, 3-drug combination which are shown here, they give us very high response rate. And I think that is the starting point, and this is an old data, it's 2009. So this is what it used to be, already used to be 12, 15 years ago. Now we have done many other treatments and investigation, and I kept this old slide, I didn't change it for a deliberate purpose. So here in the 4th or the 5th bullet you see that single agent response rates diminish with increasing lines of therapy, it's more refractoriness. Attaining a 20% response rate in 2020 isn't easy, so I must have given the talk in 2020 on this topic. And I kept this because how wrong that statement is. So in 2020, beginning of 2020, getting 20% response rate with a single new drug was not very easy, and then there are triple and penta refractory disease, terrible. What has changed is what has happened in myeloma in last few years. What you see here is that in 2 decades, little less, 2003 was the bortezomib approval, so 20 years, 2 decades, we have 17 new drugs approved for myeloma. Almost 1 new drug per year. It's incredible compared to any other cancer. This is the best. If you look at the new drug approval over time, since 2001, in the first decade, there were 4 new drugs. In the second decade, there are 9 new drugs. And if you look at the third decade, 21 to 30, there are already 4 drugs approved. And if you plot the curve based on what we see here, we are in line to get 15 more new drugs in this decade. So if we think it is complex today, it's going to be incredibly complex in next decade or so. And that's a challenge, that's excitement. And to make the point that how wrong that statement was just 3 years ago, the first 7 drugs were approved with a median response of around 20 to 30%. They were approved for commercial use, and then combination give high response rate. If you look at the last 3 drugs, they are all approved with 60 to 90% or 95% response rate. So the field has changed incredibly, even in 2 years, with all these high response rates. And then if you look at how many in the United States, there are 5 drugs which are approved for 5th line treatment. Hopefully all them are coming in earlier line. PFS more than 6 years, OS more than 10 years. So again, we are doing better, but that's not my talk about, is not our doing better. Talk is, are we curing these people? So we need to go a little bit beyond just being happy with 10 plus years of survival. So we need to get deep response to get all this improvement. And the reason deep response is important is what we have seen in this meeting yesterday about MRD negativity. If there is a persistent myeloma, MRD positive, even though CR means myeloma cells are still there, that's not going to be an easy cure. So we need to get to where myeloma cells, at least by the current technology, is 0. And that will probably lead us to a probable curative outcome. So 10 to minus 5 is good, 6 is better. If we could measure, technically possible or physically possible, 7 would be even better. And then we include PET-CT and other measure. But we have to try and get as deep a response as possible, and then reach where either time to progression of few cell is less, or the immune system takes care of this. And you have seen this data, and which is very exciting, and I might come to this slide again, is that now if you look at patients who are MRD negative, and these are, the top one is newly diagnosed transplant eligible patient, where we started doing MRD in the beginning, 10 to 15 years ago. So those are the patients who have had at least 10 to 15 years of follow-up, and you could see that in the end, the curve has a plateau, not many relapses. There's a large number of patients, 4,000, but we are beginning to see some straight line, or at least we can imagine a straight line. again, as I said previously, this relapse patient population, although follow-up is much shorter than transplant eligible patient, that also is an exciting beginning. So I think deeper responses are great. But if you look at how much deeper we can get and how many patients, the CAR T cell are really illustrative that, this is 6-line treatment. We get 98% response rate, 80+% CR rate, more than half patients getting MRD negativity, and then now you look at the survival curves, the PFS here in subgroup of patient population, sorry it is shifted, but what it shows is that patients who have more than 12 months of sustained MRD negativity, their relapse rates have gone down significantly. Just first 2 years of follow-up, these are all very new studies, but it is significantly increasing. And similarly, if you look at same patient population, even for overall survival, lots of patients are following without having any overall survival related events. And so incredibly deep responses, and some of them seems to be maintained. We need to have 3 to 5 more years to be able to say that these patients are probably not going to relapse. The third point is for cure is should the cure mean that patient is not on any treatment? And the standard pitch we all have for our patients, and patients complain, I'm taking all these drugs, when can I stop? And there are no side effects. And so the point is, just because it's a cancer drug, they want to stop it. If it's diabetes, they have no problem taking metformin or insulin, even which is injection. But lenalidomide, it's an easy drug. If it is not toxic for the patient, they want to get off. So should they get off treatment or not? In my mind, if they are on treatment, I don't think it matters, as long as they have a normal quality of life. They can take one Revlimid and live for next 50 years. I think we don't mind. So I think, should they be on treatment or not? My guess is that a lot of patients will require treatment for a certain period of time till we define that how much sustained MRD negativity is curative and we can stop. So for that, we'll need longer follow-up. But you could see that as we continue the treatment, and this there's a bar at the top, there are different control, then thalidomide group, proteasome inhibitor group, len stopped early, and then the last one, len continued at PD, and you can see they have a more sustained responses, etc., and they remain in PFS, a larger proportion. And so I think this is an important, that probably we will need to have some treatment for current purpose. And if you look at this meta-analysis that looked at maintenance less than 2 years versus more than 2 years, 2 of the EMN study combination, clearly see that those who continued, the blue bar, are doing better than the yellow bar. So our expectations should be myeloma doesn't come back, but they may need something to maintain it, at least for a certain period of time. And then immunotherapy, I won't go into all of it. Nupur described beautifully all the various things we are doing, both active and passive immunotherapy. The active one could be less toxic and can be utilized, which includes IMIDs as well in the active part, includes vaccination. Some of them are there, but not yet where clinically it can be utilized. But the passive one, the antibody-based treatment and the CAR T cells and the bispecific are the most important one for sustained remission to keep the disease in control. So that's the third bullet. And the fourth bullet is, should the cure mean that there is total disappearance of all the clones, or can an indolent MGUS clone persist? And that's an open for discussion as well. If we can confirm that this patient really has an MGUS, then I guess we may not mind if it stays for 20 years. But there is no way to be sure what is there is MGUS. And in absence of that, I would submit that we should try and get rid of the clone if we can. And so that is the important point to keep in mind. So now the question is myeloma curable with all the things we have and all the things we are doing? Or the alternate question is, are we curing myeloma? So again, back to the same thing, I would think that the straight line at the end in some of this data, 4,000 plus, and this is overall survival, suggests that patients are not dying beyond certain years. And that is very, very encouraging. I'm still not saying cure, which I might say in the end, but I think that's very encouraging. So we have to look at all different data sets. This is another older data set, and you can begin to look at the curve for PFS. One is a Pathema study, other one the Italian study, that between 25 to 35% patients have a beginning to have a plateau, and we can imagine and use a creative imagination, and we begin to see that certain proportion of patients are not relapsing within 10 years. So these both studies have over 10 years of follow-up. So sustained CR, now hopefully sustained MRD for 10 years, what would it be? So why are we not calling this cure? There was also a study done, it was a study done by the Arkansas group to looking for cure fraction from all various data set. And what it said is that even if you look at the old data set, proportion of patients who are meeting or exceeding the predicted remaining years of life is around 15 years. And that's almost for 70-year-old is within the range of where they might die from something else and not from myeloma. So all very positive news about cure in myeloma. So where are we in regards to cure in myeloma currently? And these are the curves for ALL. That from 1950, there was a clear plateau. So in ALL, we didn't have to imagine. 50, 60, 70, 80, the curves have gone up. The curves are not too dissimilar in some ways to what I showed you, the total therapy data. We are right now 15 to 20%, where the curves are sort of staying steady. And we have to believe that these are old patients. So at some point they are dying and not from myeloma. So we have to have myeloma-related death studies to be sure what's happening there. So then with all this data, why am I not, me or you or everyone, not calling it a cure? So there are three cases here, and I'm going to ask you this question. So let's go to the first question. And I want you to say, do you think this patient is cured or not? So a man received chemotherapy for testicular seminoma 20 years ago and is NED since. Do you think the patient is cured or not? Does anybody think is not cured? Okay. So in the analysis, 92.9% patients, this was a large study done by Brigham and Women, our hospital, in a community oncologist. So these questions were asked to oncologists, not to general internist. And there were still 7% patient after 20 years of NED seminoma said he's not cured. Okay. Second case, a woman treated with CHOP for DLBCL 20 years ago and is NED since. How many think this lady is not cured? So in the study, 83% said cured, 17% said they don't think this person is yet cured. Okay. Third example, a woman treated for a stage 1 ER positive ductal carcinoma 20 years ago. When she was 47-year-old, she received adjuvant 4 cycles of FSE, or no, cytoxan adriamycin, and then 5 years of tamoxifen, and she has been NED since. Stage 1 disease, ER positive. How many think that this lady is not cured 20 years later? No recurrence so far. Okay. So, 47. More than half thought that this lady is still not cured. So what does this tell us? This tells us, as an oncologist, we are skeptic, and that we are not bold enough. And myeloma people, all of us included, are even more shy of calling a cure. And I think that's what we need to overcome, because we have good data to show that certain proportion of patients are cured. So we are optimists, but we are too cautious. Even one late relapse after 20 years, and I had seminoma in my previous life, I used to work on testicular cancer. If somebody relapses after 10 years with seminoma, that happens. But that doesn't mean the rest 99 are not cured. So we have to come out of that one example. So what I would submit to you that it is not only curable, myeloma, but I think we are curing a certain proportion of patients. We don't have good markers to say who they are yet. We have some ideas, but those patients live their normal life with or without maintenance, and they eventually die from other causes. And so task for us today is to increase that proportion from 15 to 20 to 50%, and with all the good things we heard in this meeting, I think we're going to be there. So thank you very much.
So, very fascinating, very fascinating talk. One of the thing, with the recent developments which have been taking place, do you think in future there would be a time and which you can put a category in your curable, this thing is to little bit extend the definition of MGUS to include some SMM, and rest of the SMM actually goes to myeloma, and we take away the total category of SMM, so that somebody who is MGUS, he will remain as MGUS, like showed, and SMM already acquired, and we treat them. Now we have so many tools. This definition of high risk SMM, low risk, and with different definition, it creates so much of confusion among the residents. I'm sure that probably that you think would come a time in future.
Absolutely, you spoke my mind. I think there will be a time where I would say SMM is dead. Either it becomes my MGUS or we treat it as myeloma. Right now, ultra high risk, super ultra high risk, etc. And we are beginning to treat them like myeloma. Why not call it a myeloma? So the way we started with the definition, and no disrespect to all my senior colleagues who came up with it, we are stuck with this right now. Time will come when this spectrum, the continuous variable, will change to dichotomize to groups based on whatever features that will happen more clearly if we know we are curing it. So if we can cure myeloma, we can cure SMM as well. Right now we don't do as much, and then we are not sure. If you look at all SMM results, none of them are yet cured. So we want to cure them, but that's not where we are. So I totally agree with you. Okay. So thank you very much.
Thank you, Dr. Nikhil. Our last talk for the day is by Dr. Shaji Kumar, sharing with us his thoughts on fulfilling the unmet needs in the management of myeloma. We cordially invite Dr. Shaji to the dais.
I guess it's good afternoon, and thank you for staying till the last bit of the conference. And I just want to again reiterate my thanks and congratulations to Hari, Uday, and Pankaj for this wonderful meeting. It's a challenging task for me to come after Nikhil and all the wisdom that he's imparted in the past 20 minutes. What I'm going to try and do is kind of build on to what Nikhil just talked about in terms of the concept of cure in myeloma, and what are the unmet needs and what do we need to focus our future research on in order to get there. These are my disclosures. So I think when you think about the how we want to address, again, this is not just myeloma but all plasma cell disorders, but I'm thinking about the spectrum of MGUS, smoldering, and active myeloma for the purpose of this discussion. So first question is, can we prevent myeloma? And if you prevent myeloma, are we talking about primary prevention, that we actually prevent a monoclonal gammopathy from ever happening, or is it a secondary prevention where we actually going to prevent the MGUS from moving to myeloma? The second question is, if we cannot prevent myeloma, can we cure myeloma? And I think, again, Dr. Munshi nicely went through that whole concept, and I will limit my discussion on that part. And finally, if we cannot cure myeloma, let's say there's going to be a proportion of patients where we are not going to be able to cure this, can we control the disease and make it into a chronic disease? So I think that in order to reach there, we have to achieve other things as well. First of all, we need to understand the etiology of the disease, and I would say this is one part where the biology or the progress in terms of understanding the biology has been relatively limited in terms of all the studies done. We need to understand the mechanisms of disease evolution, and I think we have made significant progress, as you heard in the past day and a half, in terms of the genomic changes as well as changes in the microenvironment. Now, in terms of curing myeloma, we certainly need to, as was very nicely outlined by Dr. Munshi, we need to first understand, how do we define cure, and also understanding what is the changes or alterations in the tumor microenvironment that defines cure in this disease. And finally, if we cannot cure the disease and make it into chronic, disease, then we need to understand the mechanisms of disease relapse and drug resistance. So we already talked about this in great detail in the past day and a half about the spectrum of monoclonal gammopathies going from MGUS to smoldering to active myeloma, and how this is associated with increasing disease burden. Now we know that MGUS starts early and it evolves over a long period of time, and we know there are certain risk factors that have been identified. There's clearly genetic risk factors as exemplified by the increased risk in the Africans, people of African ancestry, as well as the familial increased risk. We also know there are environmental factors because of the increased risk amongst individuals exposed to pesticides and radiation. Now the question is, can we actually predict who is going to develop MGUS even before the MGUS happens? And these are studies that were done, so relatively small study where we are able to show that individuals with polyclonal elevation of light chains actually have a higher risk of subsequently developing monoclonal gammopathy. Now obviously there are a lot of factors that could have driven this, including chronic infections. So we, clearly a lot more that needs to be understood. But if you were to actually try and prevent MGUS from happening, we really need to be able to understand who is going to develop MGUS. So that is really going to be, I think the really long or short here, because we have barely started scratching the surface of what actually causes monoclonal gammopathies. And we clearly need better estimates of the prevalence and incidence, and also the timing of the initiation events. And we have very little knowledge in terms of the MGUS in the early years. We have a lot of data looking at once it's happened in the older patient population. We have very little in terms of studies in terms of when the MGUS is actually starting to happen. And that is primarily because of the very early age of onset, and the fact that by the time you diagnose this at age 50, a lot of those studies have inherent recall bias to understand what would have happened 30 years ago. And at the end of the day, many of the strategies that we may have to prevent MGUS may not have a favorable risk-benefit ratio. But something that is probably a little bit more reachable in the next decade or so could be to try and prevent the progression from MGUS or smoldering to active myeloma. So there are three important questions in order to try and make that happen. One is we need to know who has it, so that we need to identify them through screening. We need to know who will progress once they have it, and that is where the risk stratification models come in. And we also need to define how do we, if you're going to try and prevent the progression, what kind of treatment approach do we use? What is the right time to intervene? And again, are we trying to eradicate the clone, or are we trying to just delay the progression to active myeloma? We know that we don't recognize or identify the vast majority of people with monoclonal gammopathies, as has been shown in some of the epidemiological studies. And in fact, when you look at the recent ISTOP-MM study, you can see again, the proportion of patients with monoclonal gammopathies from the Icelandic study was clearly more than what we had anticipated based on the previous epidemiological studies. But they're also asking a very, very important question, which is, you don't want to screen for a disease and identify it if you cannot do anything about it. And that only will contribute to patient anxiety. So the ISTOP-MM study is going to answer a very fundamental question as to, if you screen, are we going to be able to make a difference? They have three different arms where we just do no further workup, you actually do more intensive workup, or you do more intensive follow-up. And what they have already shown is that we can certainly identify a lot more patients with something that's more beyond MGUS by doing this more intensive approaches. The question is whether that's going to actually translate to a better survival in the longer term. Clearly, having more sensitive techniques like mass spectrometry, we talked about quite a bit, we can identify more and more people with underlying monoclonal gammopathies and probably identify them early on. Whether that again will translate to a better outcomes for these patients, it's unknown, but one thing is clear, if you can identify these people early on, let's say in the 20s, in the second or third decade of life by using mass spec type approaches, I think we are going to get to understanding the etiology of these conditions in these people. So could the future state be looked like something like this, that you do a extremely sensitive mass spec based assay at the age of 50, and if you are negative, your risk of developing myeloma for the rest of the 4 decades is practically zero. We don't know that. We are actually in the process of doing this study where we have taken all the people who are negative on the Olmsted County study, who are negative by traditional methods and doing mass spec on them, and when these people have follow up on. So if you can demonstrate that if you're negative at age 50 and you never develop myeloma after that, that would be a one-time screen that we could certainly apply in a population basis. And clearly if you're positive, then obviously we need to categorize them and do the appropriate interventions. So we already talked about the smoldering myeloma progression rate. We know that this is, again, it's a heterogeneous category, more clearly made from a clinical standpoint rather than from a biological standpoint. And these people have a much higher risk of progression in the first 5 years, more so in the next 10 years. But after that, these patients essentially have the same risk of progression as muggers, telling us that the smoldering myeloma category was, again, a heterogeneous basket of people with myeloma and people with muggers, and just we had the luxury of time to define who really has muggers and who really has myeloma. We already know that the progression from smoldering to active myeloma is accompanied by changes not only in the tumor cell, both genomically and epigenetically, but also in the microenvironment from an immune perspective, as well as in changes like angiogenesis. So we do know, based on the risk stratification system, who are the people at the highest risk of developing or progressing to active myeloma. Again, these are not perfect systems, but they are the best that we have today that we can apply in the clinic. And there's a more granular version of the risk stratification system we talked about the other day from the International Myeloma Working Group. And we know that we can make the systems better by incorporating some of the genomic factors, and these are some early attempts at trying to do so, including like gene expression panel on the right hand side. Now the whole concept then is, if you can identify the people at high risk of progression, can we actually intervene early? With one goal could be just delay the progression, and which is what was pursued in the Spanish trial, showing that there is again delayed risk of progression as well as improved overall survival with early intervention. The second question is, what Dr. Munshi was talking about, is can we cure these people by intervening early? He already showed data suggesting that the genomic complexity does increase as the disease evolves. So potentially by intervening early with a really intense therapy that can provide deep responses, can we cure a higher fraction of patients? We don't have the answer to that, but we are already in the process of having done those trials and large cohorts of patients who are being followed long term. And this is the GEM-CSER trial from the Spanish group, again using a transplant-based approach, proteasome inhibitor IMiD induction. And we also presented the data from the ASCENT trial at the recent ASH meeting, looking at a non-transplant based approach, again taking into consideration some of those mutational changes that we know accompanies high-dose melphalan. So instead we used a 4-drug combination given for a defined duration of treatment. And we know that we can get the vast majority of these patients into a complete response, and in fact almost 2/3 of the patients are MRD negative with this kind of approach given over 2 years of therapy. The big question is how many of these patients are actually going to never get myeloma and die of something else. The whole concept of cure as defined in by Dr. Munshi. The problem is what do we do? Let's say we cannot prevent the progression and the people do actually get myeloma. How can we actually treat them? And we know that we already have redefined some of these patients with high-risk smoldering myeloma or ultra-high-risk smoldering myeloma as having myeloma, as Dr. Malhotra already was alluding to. And that added all these additional criteria to the original CRAP criteria. So if people have this high risk, whether ultra high risk or the traditionally defined active myeloma, the question is, how do we cure them, or how do we know we have cured them? And I'm not going to go through it in much more detail. Dr. Munshi already covered this, but from a patient perspective, what you really want to do is to have a normal life expectancy, low risk of recurrence, not being on therapy, and preferably no long-term consequence of the prior therapy. This is the same curve that Dr. Munshi showed, and just to highlight how myeloma is different from other hematological malignancies. In both Hodgkin's, diffuse large B-cell lymphoma, and follicular lymphoma, if you survive 36 months without progression, your risk of progression is dramatically low. In fact, there's none for Hodgkin's. But in myeloma, unfortunately, even if you survive for 3 years without relapse, you still continue to relapse after that. And so then the whole caveat about, are there going to be a subgroup of people who are going to just reverse to muggers? We all have patients in our practice who have tiny M spikes, whom we have been following for 15, 20 years. Are they cured? We don't know. I think that's one place where we really need to do a lot more studies to understand what is at a single cell level or at a single cellular level, how can you distinguish between a cell that is destined to over time become myeloma versus just they are clonal but has practically very small or no chance of becoming malignant. And it may be that it's not just the changes in the tumor cell, it could be that we have to revert the microenvironment, especially the immune microenvironment, back to where, what it might look like in a normal person. But where we are, which is the alternate, which is we have, I think already, as Dr. Munshi showed, we certainly have functional cure or practical cure, which are basically prolonged remissions without therapy, and we have prolonged disease control without, it could be either of these two. Either you have prolonged remissions and no therapy is required, or you could have prolonged disease control but you have to treat them intermittently over time. But eventually at the end of the day they die of something else and not because of myeloma. So how can we achieve it? Obviously we need highly effective therapies, and we already saw that we have good combinations, especially the 3-4 drug combinations, which can give you really deep responses. Now the question is, can we adapt these therapies to the type of myeloma we talked about, myeloma that the patient has? And we did talk about having different types of myelomas based on the driver mechanisms in terms of a genomic type. And I think for this we really need to again understand the risk stratification approaches. We need to understand how different agents or different approaches might change the outcomes for specific subtypes of myeloma. And we also have talked about, to some extent, adapting the treatment to the response. And this is important because one of the way we want to define cure is that patients are off therapy. So trying to understand what depth of response is good for a patient, appropriate for a patient for us to stop therapy. So I think one of the things we have learned in myeloma over the time is the outcomes are dependent on 3 things. One is the underlying risk of the disease. 2, the depth of response that you are able to achieve. And 3, the type of maintenance therapy that we have to use in these patients to maintain that clone under control when there is still residual clone. So I think our goal is to get the best possible treatment package. It can give us the deepest response, longest duration of response with no long-term toxicity, which is well tolerated and allows for treatment-free interval. So this is where I think a lot of our future clinical trials are going to be designed to address. Now current approaches, you already know that we can get a median progression-free survival exceeding 6 to 7 years in the transplant patient population, as we saw with the Cassiopeia trial, or exceeding 5 years in the transplant ineligible patients with DRD like in Maya trial. So where do we go next? So I think the specific questions that we can try and answer in our clinical trials: can we improve the injection therapy? Can we leverage the power of some of those immune therapies that we just talked about? Can we improve the consolidation therapy by either replacing or adding treatments like CAR T cells to the transplant? And what is the ideal maintenance? Is it 1 or 2 drugs? And what is the duration of maintenance? And whether everyone needs maintenance? I'm sure there are going to be a subgroup of people who have relatively indolent disease who might do just fine with their limited duration therapy and no maintenance is needed. And then the question is, how do we approach different myelomas differently? We already know that based on the underlying spectrum of genetic abnormalities, that we are dealing with a set of genomically diverse disease but phenotypically very common or uniform presentation. And what makes them different is the tumor. There can be tumor clone characteristics like the genetic abnormalities, host related characteristics, as well as some things which represent a interaction between the host and the clone factors. So what we really want to do is to try and develop therapies which is adapted to the underlying risk of the disease. So what we have in myeloma today is you have, just looking at the risk, you have high risk patients who have a short survival, low risk patients who have good survival, those 35% patients at that tail that of the curve that Dr. Munshi showed. What we want to do is to develop different therapies that we can apply to these groups of patients, which will take us to this place where they all have equivalent outcomes based on the different therapies that we give them. Now, unfortunately, as we all see in the clinic today, most of these patients are going to relapse despite having, or a significant proportion of the patients, despite having these high intensity quadruplets and transplant and long-term maintenance, they're still going to relapse. And we know we have understood to some extent the mechanisms of relapse and the whole concept of clonal evolution. and how subclones can evolve under the face of or the under the pressure of specific therapies. So could be one approach be that we actually understand the genetic drivers of the individual disease and try to target them. A good example is like these the MyDrug study that we are doing, which is again genotyping all these, doing sequencing in all these tumor cells, understanding what are the more dominant mutations that we see in those patients, and then go after them with a specific drug. For example, if you have a RAS mutation, can we use a drug like cobimetinib in combination with a standard myeloma backbone? Or if you have 11-14 translocation, can we use a venetoclax based therapy? Now another approach is obviously, we have already seen the power of the immune approaches. We won't go into more detail. We saw how effective the bispecific antibodies and the CAR T cells can be in very late stages of the disease, even after having seen 5-6 lines of therapy. So what's a good, there's definitely good news and bad news here. So good news is we have multiple effective therapies with different mechanisms of action. The bad news is we just don't know how best to sequence them. And I think that is one of the things we really need to understand is what types of myelomas need what type of therapies to be used in the upfront setting to get us the maximum benefit. And to do that, we need to have better understanding of the disease biology and the heterogeneity in this disease and match that with therapy. So certainly that is an unmet need for us for the future. So just going back to that whole question of, are we getting there, right? I think this is again data from the Mayo Clinic cohort looking at it over a time period, and I wanted to focus your attention on the latter time points, especially when you look at the 2009, 2013 and the subsequently. These blue lines on the top, those are patients with standard risk FISH ISS stage 1, and you can see that even in 2009 and 2013, people under 65 years of age, their survival is almost reaching that what we would expect for those age adjusted normal life, again the curve for the normal population. And when you look at the most recent cohort, you can see both the older and the younger patients. If you have ISS stage 1 disease with standard risk FISH, your survival is almost reaching there. Now of course, this is a limited duration of follow-up. What if these curves go out to 20 years? Are we still tracking with those? We don't know that yet. But so I think in the future, what we will be doing is, I think we will be screening, we are likely to be screening for monoclonal gammopathies at some point in time. We might be doing a more enriched screening depending, targeting the high risk population. I think based on the risk, we will treat a proportion of them and possibly cure some, and the rest we will delay the progression to active myeloma. And with the more effective therapies that we have, we are going to cure more and more of these patients once they get newly diagnosed myeloma. And in a proportion of them, the disease is going to still relapse, and in those people with the newer therapies, we can control the disease for long enough that we are hopefully giving them a functional cure. So I'll stop there and thank you for attention.
So can I have a comment, sir? Like, sir, a steroid-free regimen for myeloma is one of my dreams to be true. Do you have a similar dream with so much of therapies available? Do you foresee, at least in near future, at least beyond the realm of renal impairment and maybe cord compression, we may be able to get the steroid off the block in induction, at least in myeloma?
Oh, I think absolutely. I think so. There was the study that was presented at ASH looking at daratumumab with a steroid, less intense, I should say. I wouldn't say steroid free because they did use steroids the first couple of cycles. So I don't know if you will be able to get off steroids completely. We might need smaller dose of steroids to avoid some of those reactions to immune therapies. But the way we've been using steroids with higher doses, I think that's going to go away. You can clearly see the evolution. With the E4A03 trial, it was shown that high dose, the 4 days of dexamethasone went to once a week. With the Italian trial showing that beyond 9 months, you don't need dexamethasone, we already truncated to 9 months. And now with the data like this one, I think we're already starting to see the beginning of the end for dexamethasone as a treatment for myeloma. Okay. All right. Thank you.
Thank you, Dr. Shaji. I now invite Dr. Uday to take the stage for the valedictory session.
I thank all those people who are still staying back till this stage, till the flag end of the meeting. And that's why we have kept the perspective talks or the plenary session to the last, the best of the talks for the last. Okay, so I have a duty to announce the prizes, and for this I would request Dr. Pankaj, President Image, Dr. Harimenon, Organizing Chairperson, and for the first set of the awards, Dr. Nikhil Munshi sir, to please kindly come onto the stage, please. I understand many of the people have their flights to catch, so if at all, if the winner is not available in the auditorium, any person on his behalf from his institute might come forward and kindly take the award. So, firstly, I will announce the awards for the oral papers. So, the third prize for the oral paper category goes to Dr. Aditya Jandial from PGI Chandigarh. He has presented the data on the MGRS. Okay, anybody from PGI? Otherwise, I will request Dr. Pankaj, his mentor, to collect the award. But Pankaj sir, please ensure that you give the cash award to the student. So we have 60,000 rupees award as a travel award to the third prize winner. For the second prize, we have Dr. Shelly Singla, again from PGI Chandigarh, BCL2 expression in plasma cells for the myeloma. So this is the 80,000 rupees cash award to the second prize winner. And for the first prize, we have Dr. Sumit Mirg presenting data on the various, okay, Dr. Bhausab is here. So he has presented data on the various mobilization regimens over the last 12 years. So he gets a cash award of 1 lakh rupees and our observership program in US. For the second set of prizes are for the e-posters. I would request Dr. Harimenon and Dr. Nikhil Munshi to do the honors. So for the third prize, we have Dr. Reshmi GS. Okay, you are here? Come, please. Dr. Reshmi, please introduce your topic, please. What was the topic?
My topic was a clinical audit of risk stratification documentation.
Amrita, yeah, good. For the second prize, we have Dr. Harshini Sriram for the e-poster section. Yeah. So this is a cash award of 30,000 rupees. Harshini, this is unfair. Every year you come up and pick all the cash prizes from the image. Introduce your topic, please. Introduce your topic.
My name is Harshini. I'm a graduate student at Tata Memorial Center, ACTREC, and my poster was on plasma microRNA as biomarkers for response prediction and clinical outcomes in newly diagnosed myeloma.
Thank you. And for the first prize, we have Dr. Pavitra Subramanian from PGI Chandigarh. Okay. So the first prize for the e-poster is 50,000 rupees for Dr. Pavitra. So Pankaj sir, please. This time TMC and PGI had the highest number of papers, PGI 9 and TMC 9. So, thank you.
This This paper was on comparison of PET CT scan with the diffusion weighted MRI comparison, and as per Dr. Nupur Raja, this is the largest studies. Even I don't know, because the 20 patients and it was 30 patients. So even 30 patients can be the largest study. So this is a message for the the residents to do these kind of studies. Thank you.
Thank you, Nikhil Munchita. Next, I would request Dr. Nupur ma'am to come onto the stage, please. So now we would be announcing the quiz awards. So the third prize for the quiz goes to SGPGI Lucknow. So we have anybody? Yeah, wonderful. So Dr. Purvi Kapoor and Dr. Nitin Chaudhary. Last year you were the winners of the quiz. Come, Dr. Purvi and Dr. from SGPGI Lucknow. The second prize for the quiz goes to Madras Medical College, Dr. Dinesh and Dr. Gayatri. It's a cash award of 50,000 rupees. And the winners for the quiz for this year are Nizam Institute of Medical Sciences, Dr. Shushmita and Dr. G. Sindhu. They have a cash award of 1 lakh rupees. And we would be helping you for international observation program. Thank you, Nupur ma'am. I would request Dr. Shaji sir to come onto the stage, please, for giving away the awards for the undergraduate section. And I'm really proud that this time we could give some prizes for the undergraduates as a society. And for the first prize for the STEM talks, we have Dr. Shreyasi Seth. Dr. Shreyasi, please come over, please. You should introduce yourself. Which college, which year?
I'm Shreyasi Seth. I'm a MBBS graduate from School of Medical Science and Research, Sharda University, and I'm a resident of Delhi. Thank you.
For the second prize, we have Dr. Neha. Dr. Neha, please come over. Yeah, it's not technically right to say Dr. Neha. Neha, Miss Neha, who is going to be doctor soon. Introduce yourself.
I'm Neha. I'm from Jubilee Mission College, Kerala, and I'm in my 4th year. Thank you.
The third prize is actually for Dr. Karthik. I will request Rajat to collect the award on his behalf. Okay, Karthik is not here. Okay. Yeah, Rajat, come over. Third prize for the STEM talks. Undergraduates. Thank you, Shaji sir. I would request now the chairperson and the president to give away the participation certificates for the various industry members who have been exhibitors here and have helped us in various ways. So I would first call upon members from NATCO Pharma. Anybody from NATCO Pharma? Okay. Second would be from Intas Pharmaceuticals. Okay. So in here the message can be given for the people if the various pharma can come over and collect it. I see Janssen and Janssen here. So I really don't know how do you pronounce. You call it Janssen, Johnson, or whatever it is. So please, please come over. Thank you. Thanks a lot for participating. Thanks a lot. Thank you. Are there any other pharma please? Takeda? Wonderful. Great. In fact, Tejam, can you call the pharma people inside? That would be better. So, I request the members from the Takeda Pharmaceuticals to please come forward. So, from Takeda we have Prashant, Roy, Anil Krishna, Nandan Putti, Avi Sharma, Neha Guruha, and Rubina Khan helping us out. Okay, so with the other pharmas yet to come, do we have the myeloma friends or the yodhas around? We actually wanted them to share this stage for giving the message out to the doctors. Okay, would be preferable. And before we close, humble request on behalf of Indian Myeloma Academic Group as a secretary and also as an organizing chairperson for the next year's conference. First of all, I would like to personally invite Nikhil Munshi sir, Nupu ma'am, Shaji sir, and all our members, the international fraternity of the Indian Myeloma Academic Group, to be physically there like this year to help us out in the proceedings and to make the event a grand success. So we require your blessings and your constant support to take any of the image activities forward. And we take it for granted that your support will be with us always. So we take it as a right as the Indian Myeloma Academic Group. So we request humbly that you should make yourself available for the next year for the Pune conference. Now, I would also like to request all the doctors, delegates, students, and the heads of the departments of the various institutes, please be there in Pune next year. We are announcing it a year before, 12 to 14 January. Pune, it would be a wonderful environment like in Bangalore, similar weather, similar thing. And we'd like to make the event as successful as Dr. Hari could make it here. So we would like to match the same standards next year as well and try to do better. So I would hand over the stage to the president and to the chairperson for the final word.
I think the conference which you see and is without flaws is actually because of Uday. So I would say give Uday a big hand.
Oh, no, sir. Hari, sir.
And obviously under the guidance of Dr. Hari Man, who's the organizer. And we would like, the image is actually, we all want to improve the management of myeloma patients. And we would like, all the undergraduates and the fellows who have been, who are interested, you can approach us for international observership, or if you want to do any kind of a studies, we would try to connect with you to the international experts, and so that, we can improve the management of these patients. With that, thank you very much, and I hand over to Hari.
No, I have nothing to add, but just to say thank you all for being here with us, and nothing can be made successful other than by participation by our colleagues, our young doctor colleagues, our medical students, and of course, thank you to the international faculty to be here. You add so much value to the whole conference. Thank you so much. Yeah. And a special mention to Dr. Uday Yanamandra, who I got it right. Yeah. So, who has been the backbone of this conference and who has been I've just been on the sidelines and trying to help him out in every way I can. But so when he said you can have as good conference, I would expect a better conference because he's going to be all in all over there in Pune. Yes. Yeah. I would like to invite everybody for lunch, which is in our lunch area on the rooftop, and please join us for lunch. And thank you once again.
Yeah, if anybody wants to say anything, he's most welcome. If somebody has any suggestions or anything. Okay, myeloma friends are there.
Yes.
We were calling you, and if you. Okay, so if you the myeloma friends and Yodha are two patient support groups. So maybe we can invite Mr. Dilip Mevada, Dr. Gayatri, and Ms. Vinita Menon. So please, you can come and the stage is yours.
Yes. Thank you. What a timing. So, thank you very much. Thank you very much, Image Society, Indian Myeloma Congress 5, and the organizers of Indian Myeloma Congress 5, distinguished faculties, international faculties, and pan-India doctors. Yodas and myeloma friends. It is an important day for us. We have been associated with Indian Myeloma Congress right from its inception. As a as a patient also, what patients can do is the myeloma friends is a great example of the patient support group, patient advocacy, and the kind of work which we are doing at Myeloma Friends. It was our, interest that being an architect, when I was diagnosed with a paraplegia, underwent a spine surgery, and then followed by a induction therapy, bone marrow transplant in 2011. And it relapsed in 2017. In 2019, second relapse with a high-grade disease, 17p deletion, 1q amplification. And after that, I underwent, after induction therapy of KPD, second transplant also in 2019. Presently, I am in complete remission after the third relapse in 2021, October. I am under DARA VRD. See, the most important thing as an architect I found was to educate myself if I have to do this work. So I started educating myself and then, gathering other patients also. So gradually when we started in 2011, Dr. Saikia saw this talent towards me when I was undergoing a transplant. So it was Dr. Saikia's dream that somebody should lead this and spread awareness about myeloma. In 2011, I remembered when I used to go to the Tata website also, we used to get only homepage, nothing else of multiple myeloma. So that awareness was not there. And today we are very happy to spread awareness and take care of more than 5,000 patients pan-India and internationally. And thank you. Thank you. And I take this opportunity to expand it further. Today we have Mumbai group, Chandigarh group, Ludhiana group, Calcutta group. We are starting Bangalore group recently, just few hours, few minutes back, we had around 20 patients and caregiver patient support group meeting also. So we have already begun with Bangalore group.
Chennai group we are starting, and we would like to start many groups. And I seek all these doctors, they can help us in growing the number of groups and adding their patients. Whoever, any patients you are treating, they should come to us. Now, how they will come to us is a very simple thing. We will have the WhatsApp group, and your secretary or your assistant doctor, he will be or she will be added to our group, and that person will keep on adding your existing patients as well as new patients, and that is how we will take care of those people. Patient advocacy is very important. There are trials, बोलने जाऊंगा तो बहुत लंबा बोल सकता हूँ, but main important points is patient advocacy, drug price reduction, and trials. This is, trials should be accessible to our Indian patient also, and especially Nikhil sir, Saji sir, and Dr. Raje. It is very important that we should also have access to our patient to the international trials also, because it becomes very difficult, and that accessibility is, we would definitely, it will help many patients. Sorry? Yeah. So I actually wanted to say I wanted to continue, but छोटे में मैं इतना ही कहूँगा. We need your help, and let's grow together towards the curing the myeloma. Thank you very much.
Just a few words. We are very happy to be here with all the well-known doctors and I would say eminent myeloma specialists. We've all been a part, I think we've all known them as doctors since we are patients. And one of the things that we feel that it is extremely important for the doctors and the patients to work together as a support group, because we as patients can tell you a lot about us. And we as patients can tell you what can be better. You as doctors treat us. You know the disease, we know the body. So I think it's extremely important, and especially the newer generation of myeloma specialists coming up, take this opportunity to believe that, I wouldn't say believe, but to understand that a patient support is extremely important. You treat the body, we treat the mind. And the emotional support which is required in a myeloma journey, because we are all looking towards a cure, we are all looking towards it being a chronic disease. So I do hope that as young doctors in this field, you will be all with us. Thank you for your support. Thank you so much.
Thank you, Vinita. Thank you, Dilip, and thank you, Gayatri. So I just thought the industry partners are here. We would like to just give away the certificates. So can I invite INTAS to please come forward, the INTAS team. Gopal, come here. Let's finish. Thank you.
Sir, one photo. हाँ, sure. Sir, come. Sir, थोड़ा सा उधर होना पड़ेगा.
Sir, please.
हाँ. उधर आ जाओ. Thank you so much. Okay, thank you for your support.
Bristol Myers Squibb? Yes. And just to save time, I would just invite NATCO, please, to come, the NATCO team. Thank you.
Thank you. Thank you.
NATCO's nobody's there. And MCure Pharma, please. MCure is here.
Who else is there?
Who else is there? From that's an easier thing. MedGenome.
Okay.
Ampath Laboratories. And Lilac Insights. Anybody from Lilac? Lilac Insights? Thank you. Thank you, sir. Thank you. Okay. Thank you, Sudha.
Thank you, and we can join.
Thank you. Thank you.
You can all come. Thank you so much for staying, and kindly join for lunch on the rooftop.